remember that you don't have any retiree. You'll remember that you don't have any retirees in this program. Everybody graduates over into PEB for retiree coverage, but we do like to keep you kind of generally apprised of what's happening in that eventual transition. And then we'll just do a preview of coming attractions for the year. So that's where we are today.
Perfect. Any board members have questions?
The last thing I will say is usually we don't record the retreat, but it's a hybrid world. So we are recording the audio of this just like we do any other meeting. So just wanted to make you aware of that if you thought that maybe this one wasn't recorded.
All good. Questions? Questions, Kenzie? Nope, let's get rolling. First up, equity and healthcare access and outcomes panel discussion. We're going to start off today with an educational panel discussion regarding health equity and healthcare access facilitated by our own Dr. Heather Schultz, Associate Medical Director for the Employees and Retiree Benefits Division. And going to introduce your panel. Welcome.
Good morning, everyone. I'm Heather Schultz. As Lou noted, I am the Medical Director for the SEBB plans here at HCA. And we're going to start off this morning with a panel discussion about health equity, which means a just and fair opportunity for everyone to be healthy. And the way we measure that is looking at health outcomes. And upstream a little bit further, one of the factors that determines that is access. So we have a panel today of clinicians. I see one of our panelists, Dr. Muday, is online. And I thought we could just start with some brief introductions. Here in the room, we have Dr. Nguyen, Dr. Nguyen, and Dr. Ankeny. I will allow each of them to give a brief description of their clinical background and the work they're doing now. And I will just provide my own clinical background and let everyone know that I am a pediatrician.
Look at me. Very shy this morning.
I'm Jeff Ankeny. I'm a family medicine doctor right here in Olympia at Kaiser Permanente. I'm also the medical director for commercial business at Medicaid. And I've been here and I trained in St. Pete's, so somewhat local.
Good morning, everyone. Lan Nguyen. So I'm a family medicine physician as well for 13 years now. I am a medical director at Primera.
Good morning, Quinn. I go by Quinn. I am a family nurse practitioner. My doctorate is actually in health systems leadership and transformation. I practice as a family practice NP in an FQHC in Seattle for the last 15 years or so. I also was in academia for quite a while, both at UW and Seattle University. And here I am at HCA now for the last 3 years as the health equity director.
Dr. Muday, can you come up and introduce yourself as well?
Hi, yeah, thanks for having me today. I'm Dr. Tracy Muday. I'm also a family physician. I'm actually located in Oregon. I'm standing in for Nicole St. Clair, who is the Regent's Medical Director for Washington, and who's an expert and has done most of the work. So I'm reporting out on work that she has done, but I'm also a family doc by background, practiced in Coos Bay, so rural area on the coast of Oregon. I'm happy to be here.
So the initial questions we have are more general, and then we're going to move into, as time allows, some more specific areas, including behavioral health, maternal outcomes, diabetes, and vaccines. So some of the questions have a little bit of background before the questions. So I've given you guys the questions as well if you need to refer back to them. And I thought we could just take turns of who goes first so that it's not the same problem that you have with panel discussions sometimes where you're at the end and everyone has said everything that you think to say. So we'll start with our first question. It's known that socioeconomics and more broadly all social determinants of health are main drivers of inequities in access to care and care outcomes. What is being done to address social determinants of health that are impacting access to care and healthcare outcomes in your area of work?
Sure. So I'm going to start with my hat as the equity director for HCA. There's quite a few things that HCA does to address social determinants of health. We leverage our purchasing power to make sure that we address these things. So for example, we have worked on ways to build for health-related social needs. Over the last few years, especially through the pandemic, we've really worked with providers and with health plans on giving guidance on Z codes. These are things that we utilize to, put down like, here's a diagnosis for a certain social determinants of health that is important to address needs of these patients that we care for. So we've given guidance on those kinds of coding as well. We also place financial incentives to look at addressing quality measures. This is especially true in our Medicaid plans, not as much and in a little bit of a different way for our commercial plans, but Medicaid has some very specific quality measures as well. And then from my hat as a practicing NP in a community health center, I can speak from a community health center standpoint. We provide wraparound services to all of our patients. My patients speak over 80 languages. I speak several languages to also provide that kind of linguistically and culturally appropriate services. So the care that we provide on the frontline patient care is very much holistic. And we also think about, the cultural, the language, and the socioeconomic needs of the patients. As an educator, I'm always doing a lot of ongoing education and emphasis on that kind of care to the students and the residents and fellows that I train. So I'll pause there because I can go on for a long time with different hats. So go ahead, other panelists.
Sure, I can go next. So at Primera, we understand that there are a number of economic and social influences that impact health status and address our social determinants of health at a full population level, a regional level, and at times at a job category level and at the member level. In fact, studies show that 80% of our health is influenced by social determinants of health, like access to transportation, healthy food, safety living, and working environments. So our approach is data-driven. We look at data science, and really we have a tool where we look holistically at a visual dashboard and allow our team members to include medical directors, clinical consultants, and our pharmacists, our quality team, our case management team to look and leverage this data to inform our programs around benefit design and network, and really look at this at a membership level and think about how do we support our members. So Primera Case Managers is one that I would highlight, and they assist our members in helping them access community resources tailored to their needs. So once the case managers speak to the member and really understanding what are those barriers, what are their needs, we look at connecting members to the community health workers who are frontline public health workers, and they are trusted members in their community, and they are serving and understanding the specific needs of the members in those communities. So they serve as a liaison between our health and social services and the community to support members in accessing those services, whatever they may be, and ensuring quality and cultural competency. So our other community resources that case managers assist our members in accessing, including co-pay assistance, discounted legal services and free consultations if needed, housing and clothing assistance, food banks, and social support groups. And so our case managers really interact with our members, not only on a health benefit level, but get to know them as a person and really think about what are those barriers to care? What do they need? Is it childcare? Is it mental health needs, financial resources, etc.? So those are examples of how Primera is addressing this.
You don't have to go last just because you're on the.
Oh, thank you. I can't tell that you're motioning towards me because my camera is looking at you from the side. So thanks.
I don't know where to point.
So, I'd like to say, Regents also has a social determinant, social drivers of health risk score that allows us to look at both on the community, zip code, census tract level, and down to the member level. And we combine that with our care managers systems so that anybody that they touch with in care management, they can see that social risk score. But I think where the magic really happens is at the the interweaving of data that we have to identify people who have potential social risks together with what the providers know. So there are things that we as a payer know about households or our members, and there are things that providers may know. And really, where we get the richest intervention is when we partner together with our providers to try and fill in those gaps that each of us have, and then filter that down to that individual need and making sure that we are meeting people where they are with what they actually need.
I think when I'm thinking of, or when we're trying to think about addressing specifically health disparities, really I think of three concepts, which is training, partnership, and research. So you can't really know what you need to address until you've done some research to understand those disparities. The disparities are well published and well identified. But within our own networks, we have to figure out where those disparities exist and what to actually target. And that requires consistent and persistent research into understanding where those disparities exist. And then furthermore, the bigger question really is not that whether or not there are disparities. I think everybody in the room can already just acknowledge that those exist. It's not that they exist. The question is why. And trying to understand why is usually how you end up getting at what or the reason behind why there's a disparity, because often with enough granular questioning, you can come up with a good explanation for why those disparities exist. And then within that, once we know what that is, then training becomes really powerful. And in the Kaiser Permanente network, the providers are the delivery system, right? So there's a direct connection between the research that the health plan does and the providers that are working within that system. And so it's very easy then for that to be communicated and for that to be a holistic, organic process or approach to the disparities that we're seeing. And so at Kaiser Permanente, there's very deliberate from the national level goals that need to be met in terms of identifying, in terms of meeting health disparity needs. And then secondarily, there's really robust training that we're all doing, me because I'm a provider there, in health disparities and health equity specifically. And currently the program is called Equity Guardians, and it's a long program that goes on for months that includes both research and projects that the providers themselves are doing to better equip them to interact with population that we're dealing with, understanding that that the reasoning behind the disparities is better understood because of the research that we already did. And then moving on from there, I would say that the whole phrase you've heard before, it takes a village, is in reference to raising a child, but I think it does take a team to create good healthcare, a good healthcare system, in particular, a healthcare system that meets the needs of an entire population and all of its disparities. And that teamwork involves collaboration with outside groups, talking about accountable communities of health, the 9 communities, ACHs in the state. These sorts of connections that Kaiser Permanente or any of the organizations can connect with that specifically address community health disparities and I hear they're now called health-related social needs. We're moving on from social determinants of health, which is unfortunate because that's a phrase we all know. But either way, the social determinants of health, there are organizations that specifically address those and are equipped to address those in ways that a healthcare plan that delivers specific healthcare is not always able to address. So connecting those 3 things, research, training, and collaboration, I think is the best approach.
I heard themes of collaboration is, I think, key as an approach, right? It really is work that no one segment of the healthcare community, to your point, even outside of the healthcare community, we really need to partner with others to make headway on this. Our next question is focused in on primary care. And there are a couple questions in this question, so feel free to answer all of them or one of them as you see fit. Challenges in access to and utilization of primary care services are general concerns that are increased in rural and minority populations. What communications and systems exist in the provider and payer communities to address these challenges? Is this more a factor of socioeconomics, cultural, and or ethnic norms, geographic or other challenges? What do you believe can be done to address these factors and improve access and utilization of primary care services? Why don't we start with Dr. Muday, then we'll move back to the room.
Well, I can definitely speak to rural, and really access is access. So the problems with rural, other than the geography and driving long distances, this applies to access anywhere. I was actually trained in a rural program at Michigan State in the Upper Peninsula of Michigan, which is, practically at the North Pole. And one of the key drivers to primary care access is local school quality. 25 plus years ago, when I was in training, physicians who worked in rural communities who had left, the main concern resulting in that move out of the community was quality of local education. So I cannot stress enough how much education matters, and at every level. So, that my kids can be educated in my community, that those kids can see healthcare providers that look like them and the whole healthcare team, that I can see myself going on, that there's training available for me to become a physician or nurse practitioner or nurse. So those systems, that's the long arc. But education, even starting at the primary level, matters so much for access and just, retaining physicians who are part of the community. That said, we learned a lot during the pandemic about the power of telehealth and really started to explore the continuum of telehealth. There is definitely a value in being able to interact electronically, to not have to drive through the blizzard, to not have to drive over the mountain pass. But it's also not everything. And part of that cultural literacy and that becoming that trusted partner is having your healthcare team who you may see in the grocery store, whose kids go to the same school as yours. So I think that while telehealth is definitely a powerful tool and we continue to expand and learn how best to use that, I think that we go back to primary schools and their importance in, building both the economics of the community and the healthcare system.
Dr. Ankeny.
Certainly in the rural environment, all resources are difficult to deliver. Anything, including heat, food, all of it is difficult. There's and income is virtually always lower in the rural environment. So what can we do to better deliver healthcare into the rural environment, particularly primary care? And it is true that in recent times, technology has given us a lot more power than we used to have. It's pretty remarkable how much of healthcare, in particular mental health care, can be delivered virtually. That therefore means that as long as there's technology in the rural environment, we have an opportunity that we never really had before. I've said it a couple of times and it sounds counterintuitive, but there really aren't many positives that came from the COVID pandemic, but one thing that did is that it drastically advanced technology use for the purpose of delivering healthcare. And at Kaiser, we had much more in the works than I realized. It wasn't quite ready to go live, and so they advanced everything because the pandemic hit, and I was amazed that almost overnight, I was sitting in front of a computer talking to a patient who wasn't even in the building, having a full conversation, and actually every vestige of that patient visit was occurring virtually, with the exception of a physical exam. And routinely, if you need to, you can get by without a physical exam much of the time. It doesn't totally replace medical care. But when we're talking about rural environments, we're talking about places where people do have perhaps a cell phone, or they do have internet access. Internet access has expanded, is certainly moving beyond complicated, laden healthcare and all the details that are required to deliver that. As long as they have their internet access, suddenly there's an enormous amount of resources available to them on the other side, and it's been fun to watch. And then again, I would get back to the partnership idea that a lot of this cannot occur without community-based, community-focused, social determinants of health focused organizations that we can partner with or collaborate with that are on the ground in that area or region.
Yeah, this topic is really close to my heart. Growing up in Kentucky and doing my medical training in Georgia, that's why I picked primary care. And so, to address some other parts of the question, I think there are many challenges and barriers that drive access issues and low utilization. Studies show that historically marginalized communities are far more likely to distrust their healthcare providers and the healthcare system as a whole. They may understand the historical biases and abuses of power across the industry, and may also report their own experiences, personal experiences that have broken their trust. In Washington, 66% of primary care providers are white. So it can also be difficult for a person of color to find a provider who looks like them and understand their cultural background. So provider shortages are impacting the entire country. It is worse than in rural areas. According to a 2021 nursing education study, 4 counties in Washington are among the top 15 counties nationwide with the highest primary care shortages: Mason, South Thurston, Kitsap, and Spokane counties. So recruitment and retention can be difficult for primary care providers in those areas, and they can face lower wages than their urban counterparts, professional isolation, housing shortages, and a lack of resources. As we imagine or reimagine what it looks like to make primary care better, we've partnered with Kinwell Health in Washington to make advanced primary care model available to all Primera members. So it's an integrated whole person model of care, and the statewide virtual care clinic really opening more access to care to rural Washingtonians, where they can have a virtual visit wherever they are, school, home, or working on a farm. So Kinwell has a keen focus on health equity, which is why they have clinics in rural communities and with higher populations of color. So more than 10 languages are spoken by Kinwell clinicians. They also use United Language Group, a vendor that offers interpretive services to over 200 languages. At Primera, we have made strategic investments to improve the pipelines for future healthcare practitioners. So this include supporting the Elson S. Floyd College of Medicine for a new graduate medical residency program in Eastern Washington. The Pacific Northwest University Health Science to develop a rural family medicine educational pathway and training program in partnership with MultiCare. University of Washington School of Nursing to create the Rural Nursing Health Initiative. And the program will support 20 students each year and create clinical placements for advanced practice registered nurse students in rural areas throughout Washington. And then 4 colleges in Washington to build new educational programs to build and help LPNs support their communities. So again, in collaboration with our partners, that is how we're going to make that happen.
Question, is this interactive?
Oh, yeah, please.
Okay, I was like, not, tell me to shut up.
Sure.
Yeah. Try. A question about those 4 counties. So I assume it's a population, you're looking at number of PCPs and you're doing the calculation. But with telehealth, has their access increased is it, because I would imagine that's a different calculation, is people actually having access to healthcare through whatever means, telehealth or in person. Is there any data on that?
Yeah, I think access, I can answer first. Anyone else can jump in. I think access is hard to quantify, but data is helpful. And what does access mean? You have to define access, right? And depending on what the needs are, is it physical and or is it mental? I think those two things matter. And then our patient preference, our member preference. Most of the time we think about there are some things that you can talk, do a video visit with a provider with, and that's sufficient and that's fine. But there are other things where it's not, right? Certainly, if there are more delicate things where, I want to see my PCP, I need to come in for an exam. There are preventative exams that you can't do virtually, et cetera. So I think, there are answers to, yeah, virtual can help with access, and also what the members' needs are. And I think that varies, and really depending on what those needs are. If I want to be seen today, I have a cold versus, I want to come in a month when I have childcare and I want to get a checkup for my diabetes, right? So I think when it comes to that, it's really meeting where our members' needs are, being able to quantify it and seeing, how do we meet those needs in real time? And of course, you can start with a virtual visit and then have that relationship, build that rapport and say, hey, I'm going to schedule you in a month, whenever it works for you to come in and we'll do your pap smear, we'll do that exam, right? But I think we need to talk about and think about what our members need, how do we meet them when they want to be seen, and then how do we have that follow-up so they have that relationship with someone that, they trust.
And just a follow-up question. Do we find that in those areas we have higher ER utilization because people don't have access to PCPs, so they wind up in ERs, which is the most expensive way to deliver care? Okay.
So I'm wondering about areas where there is not adequate internet resources or where the people do not know how to use it. How do you help with those kind of things? Because if I don't know how, if I can't get the internet or I don't know how to use it, I don't know how to log on to your site, talk to people.
I think a phone call, pick up the phone and call the member ahead of time and say, hey, and getting to know them, right? Exactly that. So having this personalized conversation around how do you prefer to be, communicated with? What's the best time for you, right? And have that readily available so everyone on the team that talks to this member knows. They want to, they work 8 to 5. They don't want you to call them between 8 to 5. They prefer text, for example. Is a voicemail okay? So I think really working with every individual and seeing what those needs are. But oftentimes, if not having internet connection is one, you can schedule someone for a virtual visit and they don't have internet connection. Pick up the phone and say, hey, let's talk. Right? What are some ways we can help you?
And to that point, the majority of my virtual visits are on the phone. People don't actually care too much about the video connection, and it did occur to me after about a year of doing this that seeing them is good for me. There's clinical things I'm looking at through the screen, but for them, they're not always, they don't, it's fine for them to use the phone. So it is true that it's not ideal to not have internet access. And certainly we're getting more and more rural. We're talking about a place that doesn't have good internet access, unfortunately. But luckily that is growing, but in the places where the internet access is poor, or more commonly, it's just people who are of either a generation or a background that just doesn't use the internet to that degree. Phones are a lot more common and work almost as well as video visits. And to your point, I would just mention that the data are still emerging in terms of, is there data showing that these interventions are actually effective? It's brand new. Everything moves at light speed, and we're still the pieces are still falling into place. We're still finding out just what effects have occurred and what has happened. One surrogate marker for access would be wait times. We track wait times in the KP system. How long does a patient have to wait when they call and say they want an appointment? Is it 2 months? Is it a month? Is it a week? Is it a day? How long is it? And those wait times are falling, and we can see them falling in more areas.
Can I follow up, because it strikes me that virtual visits are a really great way of access for rural populations. And from my experience, phone visits are a better way of reaching patients and continuing conversations, even getting them linked back into care, saying in a few months, we'll get you scheduled for an in-person, but for now, I'll just call you. How are you as payers reimbursing practitioners though for those phone calls? Because a lot of practitioners are spending a lot of time on phone calls or virtual visits, but they're not being reimbursed at the rate that either they were at the beginning of the pandemic. A lot of those reimbursements have gone away. So how are you compensating providers for their time in order to incentivize them to continue to make those connections with patients, even in low barrier ways?
Yes, so providers do bill for virtual visits. It depends, audio only versus video, face-to-face, et cetera. And I think that largely because of the pandemic and the need for the virtual visit, a lot of this is dependent on, the work that's being done and the coding and the documentation, as you can imagine. And then there's so much that you can do with a phone visit, right? So the time that you spend on the phone with a member, right, that is in there. Certainly you can't document for a physical exam, but medical decision-making is another one, depending on what the member's needs are. Sometimes it is just to coordinate care, right? So that time, I'd say anything over 10 minutes, providers are billing for. And then certainly over the phone, if they're an established patient of yours, if you have a relationship with them, and you usually manage their medication, the medication refill, et cetera, right? So providers are being reimbursed for virtual visits. And it's really, just like with a face-to-face visit, a video visit or in-person visit, is the documentation, the medical decision-making, and the time spent with the patient. And that providers do bill for virtual visits. Now, how much and, capabilities are different, right? With every entity and then your patient population, what they need.
I agree with you, and as a frontline provider who deal with a lot of patients who don't speak English, theoretically, what we say we cover from a insurance standpoint, yes, theoretically it's there, but the provider burden is so huge. I easily spend an hour with a patient that I can't bill an hour for because it just isn't. I can't be like, I was on the phone with a patient for an hour trying to find them diapers, for example, things like that, or just trying to connect them with certain services that they need. So I think that is an area where we have to be really thoughtful about when we build out these policies and programs and services. We have to also talk to the providers and collaborate with providers, especially those who work with specific communities. And going back to the original question, I want to also bring in this idea of, how do we improve utilization and access to primary care? We have to define primary care better, as you mentioned initially, but we also have to talk to communities. Every community has different needs. I'll give you a quick story. I went to Yakima this past summer to talk to some of the communities there. And they were like, what HCA? What insurance companies? I only know my clinic down the street, La Familia clinic, and that's all I know. And I don't know anything else. What do you mean I have to do these other things? What are these papers that you send to me from my insurance companies or from HCA or from anywhere else? I don't understand this. And that's a different level of needs. Whereas the patients in Seattle that I deal with, they're like, yeah, I know you guys have these things here, but they're not in the language that I understand, or I don't have the transportation. Each community is going to be different. And so I would say that one of the things we really need to do better at is really elevating community voices. The work on community engagement is so important. And oftentimes we conflate community engagement with stakeholdering. And so when we are out and about trying to understand what the needs are, sometimes we pull in people who are actually stakeholders and not true community members. So one of the things that HCA is trying really hard and working on is creating standardization on community engagement. This past year, we created a community advisory team called the Pro Equity Anti-Racism Community Advisory Team, so PAIR-CAT. Very, very long acronym, but imagine a pear that has cat ears. Much cuter than the actual name, right? And we go to PAIR-CAT and present to them some of the things that we have. We've talked about our Medicaid programs. we talked about, this month, we're bringing in some behavioral health initiatives to talk to them to get, feedback and ideas on how we can improve it. And then we have plans in the next few months to also bring in, some of the SEB and PEB programs and information so that we can get their ideas on, oh, this works for us and that doesn't work for us. So I think that it's really important to collaborate, work with your providers, work with your communities, and really truly create that community engagement, not just stakeholdering.
Can I just make a sort of a connecting point? Because I was really interested in the use of data and your early comments about, we know there are health disparities, and then we talk about these processes that feel more like white dominant culture processes, not sort of linking back to communities. So I'm curious about how you're starting to disaggregate your data around telehealth usage. I think is a great example. Like, it works awesome as a working white woman. For me, I love it. I wish you'd pay for everything in every possible way in it, because I feel very comfortable working through the system. And I can imagine that is rarely true for some communities overall. And sort of related to that, I was also interested in how you're using that care management team to really build that trust. And that I think the deeper, and I run an accountable community of health in Spokane, so I'm in that in-between space between community and the healthcare system. But I think one of the things we consistently hear is, my provider team doesn't look like me at all. So I'm resistant, like, before I even try and figure out how complex the system is. So I don't know if you have some comments about the disaggregating of data that's tracking to specific disparities that we all know exist. And are there added resources for those communities?
So one of the things I love about working at Kaiser Permanente is the research that they're doing. So in preparing for this meeting, I was talking with our equity community engagement chief, and she directed me to a study that that KP just did in Washington in 21 and 22. So it was only a short time ago, and specifically identifying and asking and breaking out into each group who uses phones, who has a cell phone, who likes video visits, who doesn't like video visits, and breaking it first into different racial categories. And KP is moving away from the broad, I think there's 6 that you usually see, the BIPOC community, Alaska Native American. Those are broad, and they're moving now into breaking it into even more, because that actually doesn't capture things very well. You can't just say Asian people. There's so many cultures contained within that name, right? So so breaking it into as granular a data as we can. These were thousands of interviews that they did. And it showed, for example, one of the examples was that the African American community used cell phones at a higher rate than the white or Asian community. Good to know. Good to know. We didn't know that, and it wasn't necessarily predicted. And so I think asking the questions is the important thing, because then from there you can start asking why. A second example that did not come from this study but came from a different one is Kaiser Permanente got the bright idea to distribute blood pressure cuff monitors that communicated with the patient's computer by Bluetooth and uploaded the data straight into our Epic charts. Now that sounds awesome to me. I'm a provider. I love that idea. Go KP, you guys are great. And what we found was, but to our great surprise, again, the African American used this very, very little by comparison to the rest of our groups. Why would that be? Why wouldn't you use the coolest technology ever? Right? And it's easy to just say, well, I don't know, but we've done this thing and this is a good thing, right? And it turned out that because we were able to identify that, we were able to then go and ask the questions of people who are representative of that community, and found that in particular, that particular group really didn't like the idea of every single blood pressure going into the chart. They wanted to collate that data a little bit and show certain components of it, because they didn't really trust that system. Good to know, important to know, right? And so it's asking the questions that need to be asked. And then to your point, in the KP system, of course, the providers are the payers. And so the incentive is exactly the same. There's no difference in my day in terms of billing between in-office visit, video visit, a phone visit. or a back and forth chat. So those are all incentivized the same because of salary. And that's how it works most of the time in the HMO network. But what's really cool is that historically, that's a little bit more different if more difficult if they are a rural, in a rural environment and the provider is not strictly a KP provider. These days, now, when you're talking about virtual visits, well, it doesn't matter if it's a doc in Seattle. We are incentivizing as if they're working in their normal clinic, but it can be anywhere in the state and it still has the same incentive. So that's been a really good setup for us.
So I had a question with the telehealth thing. The patient as well has to be in the state of Washington in order to receive the services. I didn't know that. And I was like, why should it matter? Yeah, I reside in Washington, but at the moment of this telehealth conference or meeting, yeah, I happen to be right now in Hawaii. I can't have this appointment because I'm not in the state of Washington. And we have community members, rural members that are in between states often. I work in an elementary school where kids, they're gone for a couple of months, they go wherever, but they still have their primary residence in Washington, their doctors in Washington, but they can't be gone during that time and actually communicate with their doctor through that telehealth. And yet we're in a world where people are traveling and going all around the world and whatnot, but that barrier is huge as well. I don't know what you guys are doing to help counter that issue, or if you can, because it's about a license.
Yeah, it's a medical scope of practice, and I think it depends, because if it's a member that I know, right? So it's a patient of mine regularly, she's like, hey, I'm gonna go to Arizona for the winter, right? She has diabetes, and she calls me, it's a medical license, I'm a medical license in the state of Washington. If it's a patient of mine and they, hey, I just need a refill of my diabetes, I know them and I feel comfortable, then, I think that's fine, but also it's acuity, it's their safety, right? So if they're in Arizona, they have something, I'm like, I think you need to be seen, right? I think you need to go urgent care and maybe have someone listen to your lungs, you might have pneumonia or something, right? So I do think that there's that spectrum, that scope of practice too. And whether or not you have an established relationship versus someone that you don't know their history, it is best for the patient that they may need to be seen in person too, so.
It's part of it too, if you get a script filled and you can't call in a script to an Arizona pharmacy.
There's some, I would say, medical school practice related to that.
Yeah, I would hope that we start to see, because I feel like our licensing is lagging behind 21st century medicine. It's a bit absurd that there's state by state licensing. Hopefully, I mean, that's gonna take a lot of work, but hopefully we start to see some changes in that.
The military, if you can't have cross-state license, so you.
It's
Yeah, so
doable,
military
and it was
military.
done during the height of the pandemic as well.
Yeah.
There was a lot of loosening of licensing requirements to allow providers to move where they needed to. So as with many things during the pandemic, we learned that despite what we often say in healthcare, where we have to move very slowly, we actually can pivot and do things quickly. So hopefully some of those lessons will be carried forward.
Anyone know of any states where they have reciprocal agreements? The Department of Health, I assume, is the one that issues all the licenses for those states, or a version of Department of Health. Does anyone do that?
That's ongoing. I know that during the height of the pandemic, there was definitely states that partnered so that they could swap providers as they were getting hit at different times. But I don't know if that's still ongoing.
I'm told that insurance plays a role in this as well, insurance laws.
Why are you looking at me?
Just look at saying this is our. Like
It's all of our,
Okay.
the royal us.
So it's not just licensing. So there are reciprocal licensing agreements that occur that are making licensing or obtaining a license in another state more less difficult, we'll say. But then there's also billing issues that are problematic.
Understood. And we have a hand up.
I'd just like to say, I do think that we have a role to play in advocacy to change that. I recall seeing Regina Benjamin, who was the Surgeon General at the time and is a family doc who practiced in Bayou La Batre, Louisiana, talking about the aftermath of Katrina and how devastated the region was and how physicians wanted to come help, but couldn't do so because of this issue of cross-state licensing. And even as that long ago, she said, you know, we really ought to start to look at, can we treat physician licensing a little bit like a driver's license, right? You're licensed in your home state, but you can use it elsewhere. And I feel like we have lost our opportunity on several occasions to really support legislation that changes that licensing process that allows for that cross state, that still considers, you know, can we keep people safe? Do we have, you know, real person access for things if your, you know, physician is not located proximate? But I think we all have a role to play in advocacy to change those licensing rules.
Point as well, it's not just that the patient is sometimes out of state, it's also the alternative that the physician is out of state, right? And physicians tend to be mobile, and it's also true that there are places where there's greater density of physicians or providers of any type that could, in theory, access more rural places if they were allowed to, right? So I think that's a legislative issue from what I can tell, but
Yeah.
it's a worthy fight. It very much relates back to access.
If everyone was pushing towards that, I might hear it a little bit stronger. More people are saying this is a big deal. This is, if everybody's saying it, this is a huge deal. You want to go telehealth, but yet you're stopping it when it should be accessible. And I mean, yeah, if you're like, you look like you're bleeding from your neck, should you go to the ER? Yeah. You should. Go now.
It got very dark very quick.
You know, however, though, if it's your monthly behavioral health talk with your doc that you know all the time and you're like, oh, but you're in Georgia today, so we can't talk. You know, I could have lied to you and said I was in Washington. It would have been fine. Yeah, that's not a healthy relationship either. So there should be some parameters like, this is okay that we're, and I think you're right, it's a legislative thing, but how does it get pushed if it doesn't start at the grassroots level?
We use the military as an example, right? Because of the health, EHR has to be the same, you have to be able to communicate. So with, you know, TRICARE and the insurance, right? So to your point, it has to be the payer system. It is a system-wide, I mean, it's a big change, but that's probably where you should start studying, you know, if we're thinking about that. The military does that.
If we're able to get it done.
Yep.
We can learn from them.
Exactly.
I wanna address data. I know we won't have time to get to all of our questions, so I'm gonna skip to the final question in our general question section. Identifying disparities requires comprehensive review of racial and ethnic data. While improvements have and continue to be made in the collection of this data, challenges and concerns remain with the security and provision of such data. What efforts are underway to improve collection and patient comfort in providing these types of data? A volunteer would like to tackle that one. Simple, small questions.
I can start. Very simple, very small. Three things come to mind. Number one, trust. Number two, data interoperability. And then the third thing I'll talk about what HCA is doing, the recent bill that passed this past year. So I think when it comes to data, the first thing we need to establish with our communities and our patients, the people we serve, is that there needs to be to have trust. A lot of times patients or members will not fill out information that has their personal information because they don't feel that this information is going to be used in the way that will help them. Rather, sometimes they think that it could actually backfire and hurt them. And we're looking at specific communities who are like, you know, rural communities, BIPOCs, immigrants, refugees. This is information that's very sensitive, something that you and I, perhaps maybe some of us in the room will feel, have the privilege to say, I can put that in there, no problem. Who's gonna care if I, you know, put this about myself? But for others, it could be a matter of safety for them. So I think trust is the number one thing. We have to look at how to build that trust. And then number two, data interoperability. Now, maybe Kaiser has a different set of race, ethnicity, language, and disability data, RELD. Premera has a different thing. HCA has a different thing. NCQA. I mean, all of these different from federal, state to individual organization, everybody has a different set of race, ethnicity, language, and disability data. And when you have that, you can have data interoperability. And what that means is that if HCA was to receive information from each of the insurance plans, and it's like, wait, you use Black here, but you use African American here, and you use something else here, and then it's all over the place, we're not going to be able to analyze that data in the most meaningful way. And when that happens, we cannot tell the true stories of the communities. If we can't tell the true stories of the communities, we don't understand their needs, and we're not going to be able to come up with solutions for issues that are happening. So it's really important that we find a way to standardize race, ethnicity, language, disability amongst other things like SOGI data, right? Sex orientation, gender identification data. So these are all things that we have to really consider standardization of data. That said, at HCA under SEB and PEP plans, one of the things that we've dealt with for many years is this thing called public disclosure, where if we collect certain data and if we were, because we're state government, if we were asked to produce them, we're required to produce them. Therefore, it will actually impact HIPAA. And then, of course, it's going to go back and impact our trust issue. So luckily last year, people from HCA, specifically Dave and Kate over there, along with several other team members, got together and helped to pass a bill, I think it's Senate Bill 5421, where we are now able to collect information on race, ethnicity, language, and disability information without having to be subject to public disclosure, which is really awesome. And I was like, oh my God, this is a no-brainer, right? But it took so much work to just get to that point. So now in the last few months, we have a team of people getting together, working on creating the standardization of RALD data, which is really exciting. I'm part of that group. Missy over there is leading that group. It's just really exciting to see. So I'm looking forward to the next couple of years to see what comes out of that, and sharing that information with the plan so that we can start standardizing that information, and then we will have a little bit better way to have that data interoperability. In the meantime, gaining that trust. So that's my lengthy explanation. I'll stop and give other panelists a chance to also talk.
I agree with standardization and transparency and the why. And I think, you know, it's just like with any tool that we build or any data that we collect, we need to have safeguards around how we use it. I think certainly helping others understand why we think it's important to know, you know, what are those disparities, transparency about those disparities, talk about these disparities, and come to a solution, right? So that's why we want to collect it, and that's how we use it. But to help ensure that we have really a actionable and safeguard, you know, Primera engaged with an external consulting firm in the fourth quarter of 23. And really it's just to think about and be really mindful about REL data collection plan and a roadmap that really talks about safeguards and standards around usage and access. Who needs to know about it and how will you use it in the company, right? So that's super important. Designing collection methods, communicating to our members around how, where, why, and again, transparency around, you know, and is critical in building our trust with our members and a commitment that we are using it to improve health outcomes. And so I think that is one thing I keep in mind, is that we need to have safeguards around how we use it and who can access it.
And if I could chime in, I think part of building that trust, you know, that the trust is the foundation, but the next step is to normalize it. We ask people really difficult questions, very personal and private questions all the time in medicine. So understanding the reason that we ask, but also normalizing that, you know, we're gonna ask you about this. We're gonna ask you how you describe yourself.
To that point, kind of a fun project that is being pioneered and seems to be moving forward. When you check in to a Kaiser Permanente facility, there's a kiosk that you stand at and you put in your information. And the drop down, what is your ethnic or racial background. Used to be, like I said, kind of 5 to 6 broad categories. And one of the things they're doing is just to create a greater sense of, I think, familiarity and a sense of belonging. They're getting more careful about, for example, with Native Americans, specific tribes. So they're listing specific tribes in a subsection drop down, so that when you're standing in your clinic, which feels like this is my clinic, this is where I've been going for years, I can find my actual family heritage here and click on this. And I know that this is going into my chart. And then I'm going to go see my primary care doctor or provider that I've known for years. And it develops trust, it engenders trust kind of on the backside. So you know that these people know you and they've been taking care of you. So that's one of the goals, is to create that kind of continuity in relationship. Because I think fundamentally some of that trust, I mean, when we do our telephone surveys or something, there's a spiel you go through to reassure, oh, you know, this data is protected and it will not, it's anonymized and no one's going to know it. You know, it might be shared with state authorities, but is collected, collated first. I mean, that's one thing, and it's nice to hear that, but you still kind of, if you don't know who this is and it's some disembodied voice and it's just some person telling you that, that's not necessarily enough, right? But if you have this experience where you're going to a place that knows who you are, that knows enough about you to have click into a hyper-granularized, drop-down box to show who you are and say who you are, there's a lot of trust that is just fundamentally created from that, almost like, I would say, community kind of environment. So that's my thought.
To this, I think that the question of, how do we gain trust? How do we get the data to, operate, like all of these things, this is really good. But at the end of the day, as we say in medicine, if you're gonna do a test and you know nothing about it, don't do the test. Don't get that CT scan. What you're gonna say is bye. So we're gonna be collecting all of this data and we're gonna be asking people to give us their personal information. We have to be held accountable. What are we gonna do about that data? We have so much data to show disparities. We have so much to show inequities in certain racial ethnic groups or certain groups with social economic barriers, people with different gender identities. And yet there's very little being done about it. I think that we get frozen in the let's collect the right information, and we don't move fast enough to get to the point where what are we going to do about it? And when I say we, the royal we, like all of us, healthcare authority, the health plans, providers, we have to be better at this. Educators as well, we have to be better at this. We have to take to that next step and say, we're going to do something about this. And we have to be held accountable. What that means is that at some point we have to look at the data and say, last year we really sucked at, Black maternal health outcomes. This year we are even suckier. If that's a word. And what are we gonna do about suckiness, right? So I'm making all kinds of words this morning. It's okay. So we have to be better at this because we keep saying, oh, there's disparities. We don't do enough. So just something for us all to think about.
I really appreciate that, Quinn, because I think until the money starts to follow the disparity, like it is really a white dominant system saying, we really care. And the money isn't following how much we care. And so I really think too, how you build trust is when does the workforce look like me? When does, the care that I need being delivered in the way I want it start to show up. And it always feels like it's a little bit of a chicken and the egg of like, I imagine all of us would do all of the right things if the money was all there. And you can't drive that until we push a little bit. Some of it's on the policy side and some of it feels like it's an actual workflow issue at the plan to provider connection point.
I think we have time for one more question, and I'm going to jump. You segued perfectly into what I was going to bring up, which is maternal outcomes. So there are extreme racial variations in maternal outcomes nationwide and specific to Washington State as well. With that in mind, what barriers exist that impede improvements in preventable, avoidable maternal outcomes in Washington State? I think that's an important piece to remember when we think about these racial variations in outcomes. These are preventable. These are not biologically based differences in outcomes. These are access issues, racism, many different things. Dr. Muday, would you like to start?
Yeah, and here's where I'm really sad to not have Dr. St. Clair here because she has done some really deep work in this on this topic specifically as an OBGYN but you know, it took us way too long to get to it's the racism, right? We spent a long time of, well, it's education, it's socioeconomics, but also like it's the racism. Um, and I think the barriers are still, we have not substantively changed the way we provide maternity care for decades. And we still have a lack of consensus on exactly what to do. It's a complex problem, but it's not a problem that can't be solved. And when we align, when we can agree on what to do, we can make a difference. So if we looked at, for example, I think we were able to align providers and systems to say, we're not going to do non-medically indicated planned deliveries before 39 weeks. And we could all agree, you know, we're all going to get on board and we could make a huge change quickly in that process. But it has taken us too long to come to agreement about exactly what the interventions need to be for maternal safety and to reduce maternal mortality. And I could go on with your other sub questions, but I'll let others speak to that.
A couple of things. Again, yes, there's a lot of disparity in maternal health outcomes. Many of those are again, not biologically based. There are interventions that can be done that are effective that would eliminate some of those disparities. But what we're getting back to, I think, is still kind of the same problem, which is culturally relevant interventions that engender trust within the community. And this goes back to cultural congruence in the delivery systems that are available. And so again, if you have one racially dominant system that really is fluent in that particular race, you've got lots and lots of disparity that you're going to see within everybody else who's not included in that. So efforts to hire culturally competent and culturally congruent is the phrase that we've been using at KP, is a really central part of this, so that when somebody comes in who's newly pregnant, for example, they are able to see somebody that they feel like they can trust because that person looks like them, maybe has gone through similar things than they have, and that, you know, that trust is built. It's also, so within that context, how far can we go with cultural congruence? What does that mean exactly? And you know, you can have a pretty specific system. Now, we have a system where clinicians in their interviews, so our recruiting systems are now looking for and targeting cultural congruence in the interviewing process. Multilingual or bilingual or from minority communities are recruited heavily and invested in the interviewing process, so that when they come in, they can be part of a system that is already focused on that. We're piloting sites now in areas that have a large subset of minorities with a full team, the provider, the MA, the nursing staff, everybody is from that same racial or ethnic background, and all share importance in that language. And I think we have 3 of them now in the state, and we're finding that there's people coming from outside the community moving in to be seen by those congruent groups. Within the maternal mortality or maternal outcomes, 2 things that come to mind. One of them is we're pioneering cervical cancer screening that can be done from home. It looks like we're to the point where we're about to just send out kits, so you can just get something in the mail. You can do it yourself. You don't have to come into the clinic and have a full pap smear. Which I used to joke with my patients, if I could figure out a way to screen for cervical cancer that doesn't involve a full pelvic exam, I will next be talking to you from my boat in Marquesas. Nobody likes this test. And so Kaiser Permanente succeeded apparently, and we're right. And so I think that we're expecting a massive increase in cervical cancer screening, for example. Also, we've made it such that medical abortions in the first trimester can be obtained through a phone visit. Despite what, setting aside perhaps the politics of that, the reality is that this is infinitely more safe than being able to just go to some grocery store somewhere and get some medicine, or all the things, the horror stories we've heard that even are worse than that when people are pursuing elective abortions. So here you can have a phone conversation with a provider. We can talk it through with you, with this person, and if they make that choice, we can walk them through that choice, put our arms around them a little bit, and make sure that they're making a good choice, a safe choice, and we can help support that process. So those are a couple of things.
Yeah, when it comes to avoidable maternal outcomes, the most concerning thing to me is that early intervention, right? If you think of someone that can get in early on in their pregnancy. But according to the USPSTF, high blood pressure related disorders like gestational hypertension and preeclampsia are among the leading causes of maternal morbidity and mortality in the US, because many of them can be managed well if detected at the right time. The task force has recommended all birthing people have their blood pressure monitored throughout their pregnancy as a screening tool. And so it comes back to our access, right? How do we get access to our members? And the CDC reports Black, Native American, and Alaskan Native pregnant people are at a higher risk of hypertensive disorders. And so besides, access and making sure that we have early intervention for birthing parents, I also think about once they get in with the providers, making sure that the providers are trained properly. And I think as humans, we all have our own biases and we have our own backgrounds. And in conversations with any patient in front of you, and I just attended the shared decision-making workshop last week, but it makes me think a lot about maternity outcomes, maternity care, and really, listening and in partnership with our members based on their goals, their backgrounds, and their cultural norms, being able to come to a decision and form that trust with our maternity population is so important. And being aware as a provider of what those biases, your own thoughts, implicit biases that that comes out, and helping with that pregnant parent make a decision towards what is their ultimate goal. So I think that's super important, the training of our providers.
Oh, I'll just add a little bit. So I'm a Vietnamese American refugee, generation 1.5. When I gave birth to my first child, I had my mother, mother-in-law, sister-in-law help me for 3 months. And they took time off work, took turns day and night, and I barely did anything but eat, sleep, feed the baby, make a mess, and be okay with it. And it was amazing with a C-section and all. I healed, I did well, I did what I needed to do, bonded with baby. It was amazing. And that's coming from a point of privilege. But many different, by the time I got to my fourth child, they said, screw it, you're on your own. But many different cultures have always embraced maternity and childbirth and all of that in various different ways. And it has worked so well for them. We come from right now, the way that we do medicine is very Eurocentric. We impose certain things like you have to have health literacy. You have to have these, like, what is health literacy? What what are the outcomes like? So I think we need to really change the way that we think about health and healthcare for mother babies and or pregnant people, babies, and really think about how we can provide holistic care, holistic, culturally appropriate, and reimbursable care. Right. So one of the things that the Healthcare Authority has done this past couple of years is really pushing for community liaisons and doulas, because studies have shown over and over again, doulas that can provide holistic, culturally appropriate care have really improved outcomes for childbirth. So thinking about that and thinking about what we reimburse, because we don't really reimburse enough for some of these things. In the end, we're probably gonna save money as a system because the outcomes are gonna be better. They're less likely to go back to, the hospital. They're less likely to be hospitalized, less likely to go to ERs. We're gonna save money. So really thinking about those reimbursable services that are holistic, not Eurocentric.
And Dr. Schultz, we're about at 5 minutes.
I was gonna just see if anyone had any last additional questions before we close up. I have had this has been very interesting and thought-provoking for me. As a summary, I would say the thing that just kept coming up again and again is this patient-centered focus in which we get them to actually trust us. And that I feel it's heartening. And I feel like that's changed over the course of my career in medicine. I think we were very much a profession where we were the experts and we told people what they needed and what that would look like. And we have finally started to get the message that that's not true. We have expertise in certain things, but individuals have expertise in the care that they need. So it's exciting for me to hear that multiple different areas of healthcare are starting to focus on what do patients actually need and how do we bring that to them.
Any final questions? Oh, yes, sir.
Yeah, I did have a question. I appreciate Quinn you bringing up community-based care for maternal health outcomes. And my first question was going to be just whether payers are going to reimburse more community-based care. It seems like HCA is really pushing that forward, but I appreciate you bringing up abortion and access to medical interventions for first trimester abortion. I wonder if any of the payers have thought or have plans if when the Supreme Court in a post-Roe environment strikes down mifepristone access to allow providers to still continue to prescribe and act as shields and reimburse in that area. So are you thinking ahead to allow this access to continue even if laws change and FDA's coverage of it is?
Yeah, that was actually one of our questions. So access to the full spectrum of reproductive health care has been in the spotlight. And like you mentioned, particularly in the US Supreme Court overturn of the landmark Roe versus Wade decision, and then removed federal protection for abortion. So states have placed further restrictions on reproductive health care, including contraception and abortion. So these new laws and regulations have restricted access to care, like you mentioned, and exacerbated really inequities among many communities that already face inequities. At Primera, our standard benefits cover reproductive health care, including contraception and abortion. It is important to note that some employer health plans may elect not to cover these services. In 2022, we began offering a new standard medical travel benefit products for self-funded and fully insured customers who wish to either add or enhance a general medical travel benefit for their employees that cover a set of healthcare services restricted in states. So this includes reproductive health services. So our integrated team of care managers, customer service agents are on hand to help guide members through this process and really understanding their benefits and coordinate the care.
I think we are reliant on the fact the political climate in Washington state is such that we are not going to lose those rights. I hope that's true. So far, that has been the indication. I don't know that that we have some sort of plan underway if suddenly these things are outlawed. I think there would be a great outcry in particular in the state. But to answer your question, I don't know that we have anything at laws that are passed that suddenly make that unavailable. But I don't see, nobody, at least in our group, is talking about that as a possibility on the horizon. We're feeling like this is great. We have this, we're moving forward with this and we are making we're making this situation a safer, more equitable and more available thing for people. As needed.
I appreciate that, and I would consider that, if like FDA's approval for mifepristone is gotten, we have decades worth of safety data that this is a safe and effective medication. So would a state or a payer continue to offer that even if at a federal level becomes more difficult to access? And the other question, and I know we're almost at time, is whether a plan like Primera, if an employer decides not to cover certain reproductive services like contraception or medical abortion, would Primera have a carve out for all members to have that benefit paid for, regardless of whether it's paid for the employer or not? So would a benefit be offered to all individuals on a Primera insurance, whether or not the employer is paying for it or it's part of their plan?
That's a great question, and I know that we are mindful in talking about these things and making sure that we, look at the market and meet our members' needs. I'm probably not the best person to answer that question. I, don't think that is an impossible thing to do. But we absolutely, when we do make policy and those kind of things, we look at the safety, of course, and in medical research, we look at national standards, et cetera. But that's absolutely something that I can see us doing and have done in the past.
I would say if you have additional questions, please
Yes.
don't hesitate to reach out to me and I can get you connected to who you need to be connected to, so we get answers for this.
Anytime.
Thank you.
Dr. Schultz, thank you. Thank you, panel. Really appreciate the discussion today. Next up, we have Missy Yates, Stakeholder Engagement Coordinator in the ERB Division. I'm gonna say ERB Division, even though it's the Employee Resource Benefits Division, but I'm gonna use the acronym. The ERB Division is gonna update us on some work focusing on increasing equitable access to healthcare created from the 2020 bargaining session with our school employees labor partners. And our materials behind tab number 3.
But if Missy comes up, we just have, well, this is a brief presentation because it directly relates to some of the conversation and then we will absolutely have a break. We just don't want to lose momentum in the connection with some of the things that were discussed as part of the panel question.
Morning.
My name is Missy Yates. I am the Stakeholder Engagement Coordinator for the Employee and Retirement Benefits Division at HCA. And I'm here to give an update on the work we've been doing with the SEB program, Equitable Access to Healthcare Work Group. So in September 2020, State of Washington and the School Employees Labor Coalition signed a memorandum of understanding, or MOU, relating to equitable access to healthcare, and a copy of the MOU is in the appendix to this package. Based on the MOU, we've been meeting to review and discuss not only the SEB program implementation, but also the benefit eligibility data by district, including eligibility by job type, which happened to also be a subject of the report done by the Joint Legislative Audit and Review Committee back in 2021, as well as global issues regarding healthcare access. And here on this slide, you'll see also the goals of that MOU. Next slide. The Labor Coalition and HCA formed a work group. We've been collaborating to meet those goals that were on the previous slide, which were identifying ways to get better insight into possible healthcare disparities for the SEB population, confirm whether there are inconsistencies in benefit eligibility across school districts, and if there were noticeable inconsistencies in the benefit eligibility, to consider policies and other guidance that could bring greater consistency in the application of eligibility standards across the state. So this slide here describes some of the collaboration efforts that we've been doing. We met over the course of several months, and in March of 2023, we developed a data collection strategy for collecting race, ethnicity, and language data, which we determined is necessary to meet our needs. Next slide. So the data collection strategy that we developed has about 6 key items from work groups conversations. And we've already discussed a few of those in the previous conversation. The first was passing Senate Bill 5421, which protects the data that we collect through our healthcare, through our enrollment information. Anything that we collect, the healthcare authority collects, is protected from public inspection and copying under the Public Records Act now. So these new protections will hopefully lead to more willingness for members to participate and provide their ethnicity and language information. And it will certainly be part of our communication plan as we move forward on this project. Next, we plan to use Benefits 24/7, which is the new enrollment system that went live this month in January, to collect and store the member data. We wanted to make sure first and foremost, though, that it went live with full functionality before we began to add anything more to it. So it was important to make sure that everything went well with that as well. We kicked off our internal work group, data work group in December to begin talking about the data collection project. And we hope, if all things go really, really well, that we will be able to collect or begin collecting data with our next open enrollment, but that timeline is tentative at this point. Third, the data collection strategy establishes a joint communication work group with the coalition and HCA membership to create a member engagement strategy. We wanted to make sure that we have a collaboration of the two groups together. And we did meet back in September to discuss deliverables, which will be in a future slide. And then we also talked about, also in this strategy, we want to make sure we're collecting meaningful data. Another slide will discuss that, and also track member engagement, see how that is done through analytics that we'll be using. And then finally, adjust those communications as we need based on those analytics. Next slide.
One thing that I do want to add about Benefits 24/7 is we're not, when we get to the point of being able to leverage that new system for this purpose as well, we're not starting from scratch. As we were building Benefits 24/7, some of the scaffolding was put in place to be able to do this. The analogy I often used was, I want a light switch, and then we turn that room on later. And so I just wanted you to be aware that some of the groundwork is there. And so, we are strategically planning and building towards that functionality. And so that's why we have confidence that once all the other pieces are in place, then we'll be able to flip that light switch, so to speak. But I just wanted to reassure you that we're not starting from scratch from an IT standpoint, because I know that many people could look at that and go, oh, that's going to take a long time. We do have some foundational aspects already built.
So what do we mean by collecting meaningful data? Well, in July of 2022, the SEB Labor Coalition work group, they set some guidelines for collecting meaningful data. So what we want to make sure we do is we want to collect data that will connect race and ethnicity data with job types and with the SEB benefit eligibility for one. I also want to make sure that it provides or shows the level of access based on the benefit eligibility by district. So that we can kind of see that. But we also want to make sure there's enough data there to be useful and comprehensive for better analysis needs. So that means we have to have a lot of data. And we also want to make sure that we get enough data from as many members as possible to represent the various demographic populations and communities that we represent. HCA then also has created an internal work group that will continue to adding to this list of criteria of what meaningful data really means as we continue working toward projects. Several months. I would like to note at this point too, that this data is going to be completely given to us on a voluntary basis. So it's going to be really important to ensure participation from our SEB population, SEB membership, and that data analysis will not only include our data, but may also include data from other partners, and that we would be able to aggregate it together and do further analysis. This is just the first step by being able to collect it through data benefits.
I had a question, because it's completely voluntary, are you expecting that you're gonna get a high response rate, or I'm thinking, no? Is there some kind of way that you're doing something to implement that, you wanna do this, please do this, we need your help on this, it's gonna help you, it might help something be cheaper later, I don't know. Something, I mean, cause it's voluntary, it's not gonna happen.
Yeah, as part of our communication and engagement strategies, we wanna build up for it, encouraging, probably get some type of engagement ahead of time to tell them about what's happening and why it's important to get this information. And again, as we see the engagement happening and the participation and the amount of data coming in, we'll adjust communications and engagement as we move forward. Again, it may take a while before we get the numbers, but the amount of data.
My question is, so during open enrollment, when they're hopefully collecting this data, it will be like your choices, then I don't want to respond. So I think it's not gonna be a separate time where you're gonna tell people, go to this and put all this data in. It's gonna be something that's gonna be incorporated into the open enrollment process.
So I think there's a couple of different, it's certainly envisioned that it will be, one of the primary ways that, or times when people would engage would probably be during open enrollment. But a lot of people don't engage in open enrollment year after year as well.
True.
But that would be one of the platforms. But, you know, we still have a lot of communication strategy to work through. But we'll do things like a tile and smart health to give you points if you go over here and work on this. And we'll pull all those different levers. One of the other things is this is all born from that MOU and collaborative work with labor partners. And so that's why we want to build the right strategy to, and it'll be a slide that Missy goes over in a little bit, about building that trust. What are the messages that will resonate? What are the, as Quinn was highlighting earlier, what are you going to do with the data? You know, and give people examples of things so that they understand what the value is added of providing this information. And then it will be the full court press of, well, here's a communication that labor partners can help share and spread out. Here's something that benefit administrators can do. We'll always dovetail it with open enrollment. If, you know, there's some opportunity that comes up, like, let's stick that in there too and get people over to this platform as well. We'll get to the comprehensive strategy aspect of it, but it will at least be part of open enrollment as a voluntary piece. And then the other trick is getting people to go into the system. And as we make more and more functionality in the system, hopefully it is something that people will become more and more engaged and want to sign into on a more regular basis and get that prompt.
Did the bill make it voluntary, or is that something that we're just doing?
The bill is all about what is exempt from public disclosure. It's about the ability for the agency to not provide something in a public records request. We're focused on voluntary at this point. Most instances of this type of information, I'm not aware of many entities where it's required, so we're kind of following that at this point.
Our district asked for all that information, and they have all that information on us already. And I didn't know if that was something that they could populate into it as well.
Oh, we can definitely explore
Yeah, because we have to.
two hundred ninety-five districts. Every district will be different, but we can certainly look into instances.
Sounds like a fun matching project.
But think about interoperability that Quinn was highlighting as well. That's another important part of all this is we're fortunate that we're building from the ground up and like what exactly the data fields will look like. And we're gonna be looking at what is CMS, what are the words they use? How do they describe it? What's Medicaid do? What do commercial payers do? And try to create more standards that I said to address some of that interoperability. I probably still on half of their talking
They know
points.
I'm a classified employee as opposed to a certificated employee. So that's definitely information that I wouldn't have to click a box that says I'm a classified employee.
So the JLARC report that was published a few years ago really highlighted some of the gaps in the information that was available. Gaps available within districts and between all the districts. And so while some districts might be doing something where they're collecting information a little bit more granularly on their membership, what are they doing with it and how can we get access to it? But also that's not being shared across the 295 school districts in the same way. So even if we were to collect information from 295 school districts, I was involved in the original SEBB report writing, which involved going out, this was back in 2014, and trying to get information from 295 school districts about the different health plans that were being offered by 295 different school districts. And even though a lot of them use similar services, it was extraordinarily complicated trying to aggregate all the information because it was collected different ways, 295 different ways of doing things, and trying to get all that information into a same comparable sort of format was almost impossible. And in fact, the report many times it was said, you just can't do this. The data is too complicated. So we had to hire a lot of really smart people to try and help make that happen. And what the JLAC report that came out recently also really highlighted was those gaps that exist. And so having a synchronous way for us to collect that, they were able to meet with JLARC and the ability of JLARC to go out and get all the information that they possibly can from all the different sources. Because when JLARC comes asking for information, every entity in the state is going to respond. You know, we're pretty Johnny on the spot whenever JLARC says, hey, we need something from you. Absolutely, we're going to be there to help get this information. School districts will be the same way. but they still just couldn't get all the information to answer basic questions. Like if we break down further than just certificated and classified, well, tell us how many, janitors you have, or how many, certain types of paras or, office staff broken down by who's been eligible for benefits, who's not. And they couldn't do that. And that was what the JLEC report was highlighting, is that there's a certain level of granularity that comes from the predominant K-12 reporting S275 data, but it's not granular enough that really it will allow us to start assessing it for purposes that we need. S275 is great for federal and state reporting requirements on education, but it doesn't really help us serve our populations from a race, ethnicity, language standpoint. So that's why JLEC acknowledged that there was that lack of data, which then kind of precipitated us wanting to take further actions on how to collect data, which then we found the roadblocks of saying there's not the ability for us to protect that data, so we need to put the legislation in place. So we're, interesting enough, while we're just at this point where it seems like the project is just starting, we've actually spent the last several years getting all of the hurdles removed for us to begin to say like, hey, this switch that we built into the system, we're getting close to turning that on now. Dave's great foresight of having that built in all the years ago, making sure that was part and parcel of it in anticipation that we would get here eventually. Well, we've started hitting the eventuality now. We started getting to do this, which will answer all these questions about things. And so that's then the next big step. The hurdle we'll have is getting the right number of people to respond to it, which is going to be a hurdle. And the legislation wasn't requiring it. I've not seen anywhere that requires that information to be submitted. And so there's a really tough value proposition for us to put out there to the membership about why this is important, how it will not only benefit them, but their coworkers will. Because I think in the school system, I'm sure that those who work in education can appreciate the collaborative nature of, it's not just a teacher and then everybody else. They've got their paras, they're going to have the support staffs that come in, the professionals that come in to support them, the administrative staff that's there. And it's really a big team effort with those schools, and be able to say, this will help you and your fellow coworkers make sure that we're covering the gaps. So you can keep doing that really amazing work you do in educating our kids. I think this is a project that will help us identify that so much more, which is a powerful value proposition. But getting that out there to everyone here is it's a pretty good game of telephone.
The internal data work group has been working on these goals, and so we formed that internal work group. Like I said, we met and started talking back in December, and we've developed a sort of a project plan. Timelines are still tentative, but the first 3 items on this list kind of address that meaningful data, and the last 2 will address the community engagement piece and our continuous improvement strategies. So in the first 3, where we're trying to address meaningful data to make sure it's captured, we want to make sure we have clearly defined categories. And this kind of speaks to what Dr. Nguyen was talking about earlier, in that, we have categories we want to collect that will meet the needs for the SEBB, but we also want to make sure we're standardized to what HCA uses, what some of the federal regulations and some of the reporting needs that we have there, and some of the other things. And so when you have all those different types of categories and they're all different, being used in different ways, how do we standardize it so it meets the needs and we can start cross-examining that data in a meaningful way? So that's going to take some time to do. Also, we want to make sure our methodology is scalable, because as you know, needs change, populations change. We want to be able to expand and adjust as our populations change as well. And then finally, we want to make sure that we have to have reports that we can be able to share with other stakeholders and other groups who need that, like JLARC, like the districts and things like that, so that we can provide a contextualized message and a more complete picture of our populations, and that will help provide better data analysis opportunities for everyone who's using that data.
And transparency.
And more transparency as well, yes. And for the engagement strategy, we're going to use data analytics to determine how people are participating with our initiative, and use our joint communication strategies to encourage participation. We want to develop engagement strategies to provide the transparency and build trust and encourage participation from our members. And then we'll also develop some training for our benefits administrators and our customer service representatives, who are those frontline interactions with members on a regular basis, so that they also will have the same type of messaging and the members are getting the same type of information from them as well. And finally, we'll have electoral campaigns and things like that to encourage participation. To explain to our members what the benefit is, what's in it for them, what's going to happen with that. Again, providing some of that accountability that Dr. Quinn was talking about, that will tell them, what are we gonna do with this data once we have it? How is it going to benefit them that we have this information? What's it gonna do to help them once we start learning more about those populations? And then with the last part of it was the implementing our process for continuous improvement. And that was to make sure that as we move forward and we do collect this data over time, continuously checking back, are we collecting the right data? Is the process moving correctly? And modify the process as we need to make sure that we are doing it the right way, and constantly looking for continuous improvement opportunities. And then the last slide, communication goals, was what I was mentioning before. The Joint Communication Group drafted a plan to have a set of deliverables, and are going to be drafting a plan of communication strategy. In early September, we met, we talked about some of these deliverables, we brainstormed on some ideas on how to engage the SEB members. But at that point, it was a little too early because we hadn't really started planning all of the other things that have to happen before we really started engaging with SEB members. So we decided to wait. Now that the data group, the internal data group has started meeting, those other meetings with the communications will resume, and we'll start working towards that. The first two items on this list, we'll need to have effective community engagement, meeting with the members, focus groups, things like that, to help build a trust and get a better understanding of what their concerns are, what their fears might be, what they feel is important to them, so that we are actually providing the information in a way that makes sense to them and makes it more comfortable for them. The rest of the list here focuses on fostering a trust that also again provides that transparency with consistent messaging, and shows a sincerity and a determination to continually improve as we move forward in our programs and our benefits plans. Again, tentative goal, open enrollment, but it may take longer before we can implement this. It's just a tentative timeline at this point. And fostering trust in that conversation with the members will take time.
I really like the idea of having like a tab through Smart Health or something, because not everybody goes through open enrollment. Also, maybe another avenue might be new employee packets, might be something else too. So you kind of hit, if you've already done it, great, but I think it's going to be tough getting this information, and you need this information to move forward.
I think it was absolutely something highlighted in the panel discussion, is how critical data will be for us to be able to make meaningful progress towards filling gaps that exist for our members. And it's one of the things I've really appreciated. I take a step back from the presentation to someone introduce Missy in her role, I think is really great evidence of what our division and our agency is doing towards making meaningful steps towards how do we engage better? How do we do better in regards to equity, health equity work, and general equity work in our programs? A year ago, I went to Dave and saying, hey, I think we need to start looking at positions that can really help us focus externally on how we're going to be communicating with members and stakeholders, appreciating the difference between the two populations, where there's some overlap, but they are fundamentally different, functionally different. And how do we take into consideration the work that is the important work we have that our agency is committed to? And you heard from Dr. Wynn talking about our commitment to health equity and what that really looks like. And Missy's presence here and giving the presentation is a great kind of example of that commitment that the PEB and SEB programs in our agency are pursuing towards working towards this. You heard Quinn say, putting kind of your money where your mouth is a bit. That's what we're doing. And Missy's position is really one of those parts where it's showing we're taking these steps forward. And it's really exciting to see this. We've had an opportunity to speak with NASHB, it's a National Association of State Health Plans, to talk about them with their data. And they brought to the table, looking at all 50 states, they brought the people they thought represented the best, the states doing the best race, ethnicity, language data collection out there. And they brought 2 states to us. They brought Indiana, which has a requirement that they're not allowed to use the term equity in any of their presentations given by anyone within their government. Literally, they cannot use the term equity when talking about equity from anyone in the executive branch or legislative branch of that state. So they brought them and they brought Utah to the table to say, hey, we want to have you learn about race, ethnicity, language data collection analysis. And so here's Indiana and Utah. We thought, okay, we have a lot of opportunity to do things here. And it's been great that Missy's position as the stakeholder and communications outreach manager. I don't remember what the title was. It's a good one. I worked hard on it. But something like that. But it we created it, we conceptualized it, and now 4 divisions in the agency are working on recruiting those same positions. Other agencies are starting to see and kind of start to mirror that as well. So we're working really hard. I take a good amount of pride to have that opportunity that Dave has really helped spearhead for us to lead not only the state in this effort from an employer standpoint, but also likely most of the states out there taking this approach to trying to collect this information for the purposes of addressing equity issues within our health plans.
It's very interesting. I'm just thinking it's 2024. Why is this just now hitting us? It's just mind-boggling to me. I don't understand.
Tired of hearing all the firsts that occur in equity spaces, but no, we have to cross the firsts off to get to the seconds and thirds.
Thank you. Sorry, Al.
No. I had 2 comments. One is I just applaud you for this body of work and probably the opportunity to help influence the school district systems who may not be collecting data in the most respectful way. I think we often see the how quickly we ask people to check particular boxes that are not actually inclusive. And while I hope with all of my heart nobody is doing that out of maliciousness, we know that is happening and it's traumatizing when you're asking people to collect data. So thinking about this, and there's also a technical assistance / system change part of it. The second part, I was curious why gender identity isn't being prioritized in this and where we see some of the highest levels of behavioral health crisis with folks on a broad gender identity spectrum. And it feels like that's going to be an area we are going to want to have data because you're going to want to have targeted programming to help support more of that. And gets me a little riled up when you talk about Utah and Indiana. So let's make Washington one of the ones where you've got to go spend your time on the national circuit. But I would just hope as we're really thinking about this, that gender identity gets factored in up there with race and ethnicity in particular.
That's what scalable methodology comes in, like scale it to what needs.
And that's, while we call it the Race Ethnicity Language Data Project, which are the kind of starting point that comes from the MOU, the labor work group we have, the opportunity for us to collect data on a aggregated level for all the school districts will extend far beyond just race ethnicity. I mean, for instance, we want to, we'll be contemplating household income. So like, let's get an idea about where the household incomes are and see if there's any relationship to the total household income and the plan selection they made. Are people with lower income being driven into plans that are maybe less advantageous for them financially on the back end when they need services, and what that tells us about what we need to be thinking or what the board should be thinking about with plans like that. So not only is it race ethnicity, it is going to be gender identity. It will be things about employment. It'll, we get into granularity like, well, what's the primary spoken language at home? What is the family makeup at home? How do you have, is it, are there multi-families living with you? Or, what's their housing situation? Starting to get into these other aspects that are social determinants of health that we can start to rope into all of this. So I think the name might be, not that it's misleading, it's just, it's been the focus, and honestly, social determinants of health, we can add as many different acronyms to it as we get there. But the opportunity is like this is saying, we're creating that scaffolding and the value statements that we're putting forward. And I think we'll start to earn trust with members, and they'll be, as they're enrolling and they're doing hopefully we never go to like a always active enrollment, which would be great for data collection, but logistically we'll have its own funding for us to try and do. That we'll have that trust in the population that as we're asking to collect this information, like, oh yeah, I get this because I know it's going to help the people around me, it's going to help me, it's going to help the people I work with, it's going to make everything, we're raising all boats in our heart.
I really appreciate that, and then would probably say, I would really think about how you're even referring to this, because I think the language in this space matters so much. And that just in the way that's being defined to me feels exclusive, not inclusive. And increasingly, I think from our body of work, we are talking about creating a sense of belonging, and that language being really much more around inclusivity, belonging. So I know that, there's sort of a technical part of stuff that I don't even understand, and I'm so glad I'm in the community doing work, not in a state agency. But I do think we have really good intent, and then the language doesn't match up with our intent, and it has a negative impact, and then we spend time trying to like backpedal on, well, we really meant this, when we probably have a little bit of a one shot at the outset to get that. I don't know, right? It's never gonna be right.
Any recommendations on an alternate name?
Something around belonging. I mean, I just think the more we talk about not othering people, like, here's the white dominant, now we're gonna compare you all to the white dominant, and rather, you know, how does this look inclusively at the outset feels important. I think there's some really, you know, might be just a helpful resource. There's some really good stuff coming out of the Othering and Belonging Center at Berkeley and John Powell's work. They've done just some tremendous work on language and how we talk about this to both inspire the movement building part, because I think we're also in a politically charged environment where we want to be careful how we're talking about it so that we're not othering people who have growth, I would say, too, on their equity journey in that way. But I think there's some emerging language work being done at a national level that might be worth looking at.
I think it's nice that we've got this great group of communications focused individuals. I think that should be one of our top things. We can say like, yeah, that's the James not the name of it's not sacrosanct. I think it's very easy to say like, let's do better, because I think it gets jargony for those of us who are just in the kind of the weeds of it all often. And I'm also trying to be very cautious about what jargon and the negative impact jargon can have, especially in the equity, DEI, belonging, and othering space. Being cautious of that. So thank you for.
And I think we're finding some of this is so technical in nature, and we work so hard to get the technical part right that we miss the communication part. And so I just think the more awareness that we make sure we've got the right technical people thinking about this, and then we ask folks like, how does this feel? Like, does this actually capture what we're trying to do, instead of being so quick to we're rolling out like, look at us, we're making progress in that way.
One of my duties is timekeeper as well.
So I'm sitting
We are
next to you,
in time,
isn't it?
so- But I'll find that out later, yeah, I'd be like, that's why we. No,
I have more ideas, my email's on there, so feel free to send them along.
we are at time, thank you, Missy, thank you, Kate. We're gonna go ahead and take a 10-minute break and we'll be back to talk about some behavioral health, so why don't we call it 11:10? We'll see you all in a little bit.
Whatever you want, Mr. Chair.
11.
I'll be on the phone.
Fired up.
Larry is with us.
All right. Carrie is with us.
Yes.
All right, members of our audience, settle down. The mics are picking up everything.
Oh, I'll see her tomorrow.
Yes,
She
yeah.
has her home.
Oh, yeah,
Morning night.
what's that?
Kidding. Sorry.
Dig in the book, figure it out. All right, everyone, we're back. Terry, have you joined us virtually?
Good morning, I'm here.
Welcome. Good to hear you.
Thank you.
All right, next up, we're gonna do a presentation on behavioral health network adequacy. Andrea Pillhauer and Dr. Schultz, again, are gonna be talking about some insights about our behavioral health network. And the tab, it's behind tab number 4, and we'll go ahead and get into the discussion.
Hello again. This topic fits in nicely with what we were discussing earlier this morning about equity and access. We are going to provide an overview of some definitions to help people level set and understand what do we mean when we're talking about adequacy and access and timeliness. So Andrea is going to start us off with providing some historical context, some definitions, how plans meet those definitions, and then I will pick up and describe a little bit more specifically about what our carriers that serve our SEB members do to make sure that they are ensuring improved access. And then we'll wrap up with a description of where members can go to learn about the services that are available to them for behavioral health specific to their plan.
Good morning. My name is Andrea Philhauer. I'm the manager of the fully insured team in ERB. And I could, if we had the time, give about a 3-day seminar about network access standards in Washington. It is a very large and complex subject. But we're going to stay very high level. And in order to talk about network access in Washington, you really need to start with sort of the historical context. The world before the Affordable Care Act and the world after the Affordable Care Act are entirely different. Before the Affordable Care Act, we did have requirements, but they were like trying to nail down smoke. They're very vague. They were aspirational, basically. They weren't enforceable because there were no bright lines to show specifically where a particular network was not providing timely access to care. After the Affordable Care Act, what happened is that carriers were required to suddenly provide this defined set of essential health benefits. And they needed to do that at particular actuarial values. Actuarial values very roughly means the percentage of premium spent on actual care versus what could be considered overhead. And those actuarial values are the metal levels that we know and love: gold, silver, bronze. So the carriers were faced with the issue of how to comply with all of these new rules and still remain profitable. And the main method that they chose was through controlling provider costs, which makes perfect sense because provider costs are the largest portion of spend for a healthcare plan. They did things like introducing new narrow networks that included only lower cost providers. They also tiered their provider networks differently to steer members to lower cost providers. And they introduced new referral processes to control the use of specialists. And the use of these methods was extremely common across all carriers. And some of the methods were concerning to regulators. And what happened is the entire country realized at the same time that we needed strengthened oversight practices for networks. Next slide, please. So as a result, the Washington State Office of the Insurance Commissioner, the OIC, did two things. First thing they did was to rewrite Washington's network access laws. They created Chapter 284-170 of the WAC, the Washington Administrative Code, which became a bellwether for other states to follow. The whole country was kind of watching that rulemaking, and much of what is in our rules was adopted in other states. Not all of the rules that I'm going to talk about apply to self-funded employer plans. So I just want to make you aware that some of the rules may not apply to the UMP plans, but they do apply to all the fully insured plans. So now we had very detailed network access requirements that are specific and enforceable because they have things like time and distance standards. Time and distance standards are requirements that members have some providers within X minutes or X miles of where they live or work. For example, for primary care providers, 80% of members within the service area need to be within 30 miles of a sufficient number of primary care providers in an urban area and 60 miles of a sufficient number of primary care providers in a rural area. And again, that's measured from either their residence or their workplace. The second thing OIC did was to establish the nation's first ever standalone network access unit. And that unit analyzes networks in detail to make sure they comply with these requirements. Plans must file a great deal of documentation of their networks, including their provider contracts with that unit. And the unit also reviews and approves requests for alternative methods of meeting requirements, the network access requirements, which we'll talk about later. This presentation is concerned specifically with behavioral health, but these requirements are not specific to behavioral health. They apply across the board to all covered services. One specific requirement for coverage of behavioral health services that is specific to behavioral health is the Mental Health Parity and Addiction Equity Act, sometimes called MAPIA, worst acronym ever. It pre-existed the ACA, but MAPIA was expanded by the ACA, and it's a crucial part of network access. What MAPIA does generally is to prevent group medical plans from imposing less favorable benefit limitations on behavioral health benefits than those that are placed on medical surgical benefits. That examples of that are there can't be higher cost sharing or longer waiting periods. Next slide. We often hear the terms network adequacy, network access, and timely access to care. And you may have wondered what the difference is between those things. They're actually very interrelated, but separate. Timely access to care, which you're going to see at the center of that bullseye on the slide, is the whole point of a health plan, right? It's health insurance is an agreement that members will have access to a defined set of services when they need them. And we're going to look at measuring timeliness of access in a little bit. And we move to network access. Network access is specific characteristics of providers that affect whether a member truly does have access to those services. It's not enough for a plan to say that we have X number of behavioral health providers in our network. The members actually have to be able to get an appointment with those providers and get the care that they need. The next slide is going to discuss some illustrative aspects of network access. So right now I'm going to move on to network adequacy. Network adequacy is requirements for the time or for the number and types of providers that need to be included in a network to ensure that all covered services are available in a timely manner. It's things like time and distance standards, mapping that shows the location of network providers relative to members, and alternative access delivery requests, which I'm going to describe later when there are not enough providers to make the network adequate according to the rules. An adequate network includes member choice. For example, there is in every category of provider rule that requires that for a specific service, if there are different types of licensed providers who provide that service, the network has to cover all of them. For example, primary care, MDs can provide that. Advanced registered nurse practitioners can provide that. Physician's assistants, naturopaths. So for every service, the member has to have a choice of providers. So you can conceptualize network adequacy, network access, and timely access to care as concentric circles the way we did. But really, the point is that they're all part of a whole. They're just distinct concepts. Timely access to care is getting covered services when the members need them. Network access is the characteristics that determine whether a provider is truly accessible. And network adequacy is the minimum numbers and types of providers needed to meet those requirements. Next slide, please. Actually, we're on the right slide. There's much more to maintaining an adequate network than just having the right numbers of in-network providers to meet the standards. Members need to actually be able to receive those covered services. And so that's network access. And network access includes things like provider directories. They're part of network access because that's how members know who the providers are. And the provider directories actually include much more information than that. There are requirements for the specific information that they have to include about each provider because the purpose of them is for members to be able to find a provider who meets their needs. Is the provider taking new patients? Is the building accessible to those with mobility challenges? What languages does the provider speak? The provider networks or provider directories have to be current to be useful. So there are requirements for keeping those provider directories updated. This is a challenge because provider directories are necessarily snapshots in time, and this information changes very rapidly. Design of planned service areas is another aspect of network access. Service areas are not allowed to be discriminatory to leave economically disadvantaged members without options. For example, there's a requirement that plans cover entire counties rather than only specific zip codes within those counties so that the plans can't cherry pick the healthy members. Referral processes are another area of network access. They're an area where delay and barriers can happen a lot and do happen a lot. So there are regulations designed to prevent delays in referrals. For example, the requirements for a referral cannot be overly burdensome. Network structure, another area of network access. This includes things like tiers of providers where there is different cost sharing for the providers depending on what tier they're in. Initially, after the ACA, as an example, a lot of plans were designed so that all behavioral healthcare providers were considered specialists, meaning that there was a higher copay for those services. That's not allowed under these rules. Tiering of providers is definitely allowed, but the member must be able to get all covered services at the lowest cost share level. Requirements for handling lack of in-network providers. We're going to talk about that in a minute more specifically, but sometimes there simply aren't enough providers to meet the standards for a certain service, behavioral health being prominent among them. And even with a significant shortage of available providers or a situation where providers will not contract with plans, plans are still not excused from these requirements. They have to find a way to meet the requirements, and that method has to be approved by the OIC's Network Access Unit. Next slide, please. I want to show you the actual language of the Network Access General Standard because there are some things about that that really illustrate the way that these rules work. For example, I've highlighted the word maintain because these regulations require that networks start compliant and remain compliant. They can't be allowed to deteriorate. This is something that the old rules just didn't address at all. So for example, a carrier will lose a contract with a hospital or with a clinic system. That carrier has to show that the network is still compliant, or they have to add new providers to meet those requirements. And the next language that I highlighted is in a manner that is sufficient. What's magic about that is that a manner suggests that there's not just one manner in which you can meet these requirements, and that's true. There's room for innovation, there's room for alternate delivery methods when necessary. Then I highlighted language to the extent feasible, because the rules recognize that sometimes there simply aren't enough type of a certain type of provider, and the regulations include specific steps that plans can take to address that situation. I also highlighted in a timely manner appropriate for the enrollee's condition because by nature, some services are routinely needed on a more emergent basis. And also the need for medical care can range from acute to routine depending on the situation. And so where appropriate, these requirements are flexible to reflect the realities of healthcare. Next slide, please. So I've been promising this slide for a little while. What happens when a plan cannot meet the requirements? The rules are flexible when they have to be. And I've talked about the two main situations when there aren't enough providers available, like in behavioral health care, or when providers won't contract. And historically, radiologists and emergency room doctors have been providers who, as a group, don't like to contract with plans. Even in those situations, the plans are not excused. They still have to ensure access to the covered services from a provider within a reasonable proximity at no greater cost to the enrollee than if the service were obtained from network providers and facilities. And the way that they do that is through a thing called an alternative access delivery request. And they have to file with the OIC this request that notifies OIC how they're going to meet the applicable requirement, even though there are difficulties. Examples of that can be some single use or single case agreements and the use of telehealth. And the carriers can't just submit these requests. They do have to show OIC that there aren't enough providers and that even if the providers have refused to contract with them, the plan did make good faith efforts to get those providers to contract. Not all providers can do this, but some types of providers that are listed on the slide can, some plans can use facilities of these types of providers in neighboring service areas to meet the requirements. And that as you look at what these types of providers are, it's because they're so important that and so rare that sometimes there just aren't any in a particular service area. Do you have a question?
Yeah, I was wondering if a carrier is gonna use a neighboring network Is transportation then also covered? So if like someone
That
has to.
can be one of the
flown or-
things they have to do, yes. Yeah, I don't know if the sound picked up the question. The question was, in the alternative access delivery situation, is transportation covered? That can be a requirement if it needs to be.
Including like medical transportation, so like
Including-
ambulance or
Correct.
evac or anything.
Yep, including medical transportation, transportation for people to accompany the patient. Yep. Next slide, please. So we've talked about requirements that are applicable to all services, and a few that are applicable to specifically behavioral health. Brennan's Law is one that is applicable specifically to behavioral health. It is in addition to all the other network access laws, and it's in line with them. What Brennan's Law is intended to do is to prevent undue delay in behavioral health care services for members by requiring that certain information be provided, prominently placed on plans' websites. And that required information includes tools to help members find available healthcare providers. It includes the number of business days in which the plan must ensure members get access to covered behavioral health treatment. It includes information on what the member can do if they're unable to access behavioral health treatment within the time frame. And also resources for people who are experiencing a health crisis at the time. For example, someone at risk for suicide or someone who is in crisis and needs immediate help. Slide 9, please. So the network access rules are not specific to SEB, and Medicare is different. But for illustration purposes, I wanted to show what the WACs require for our SEB fully insured plans. And that is that the member must be able to get an appointment for non-urgent covered treatment within 10 business days of their request. Or if the member needs a referral or the service is covered as specialty care, then within 15 business days. And what's important to realize about this is that if the member is not able to schedule an appointment on their own within these timeframes, the plans are required to help the member get an appointment in those timeframes. And I've just provided those citations for those particular requirements. So what questions do people have about that?
I'm super curious of what is the data showing on them being compliant with that 10 and 15. Do you get that on a monthly basis, quarterly basis, annual basis?
I honestly don't know the answer to that question. I am sure that OIC does get that information.
Oh, so it doesn't come here.
I don't know that.
Oh, okay.
So I see Dave writing. We will get back to you. with that
Okay,
information.
Okay, because I think that feels like that is very true in most plans, that there is that. And practically speaking, I would be curious how often that is actually met, that standard is met.
We'll take a look at that and get back to you.
Thanks. So I'm gonna delve a little bit more into the specifics of the individual plan, what you're doing to improve access to your method. Starting with next slide, Regents, administers our UNP plan. So they have a strategic initiative where they've set up a 3-year plan starting in 2022. With each year kind of building off the work that they did the year before. So in 2022, they were very much focused on expanding their provider network. And within Washington State, they increased by several hundred, both brick and mortar providers, as well as virtual options. In 2023, they were focused on, now that we have this expanded network, how do we make sure that members are actually aware of their options and getting them connected? And then this year, the focus is kind of, again, building on what's happened in the 2 previous years. Now that we are trying to get more people connected, are we getting the outcomes that we would expect? They are looking at measuring screening exams as an initial start with an eventual goal to measure actual outcomes. Next slide. For Kaiser, you'll see that there's similar themes for all of the carriers. They are also focused on expanding their provider network, and they have done that with in-person folks as well as virtual care expansion. They have a specific program where they are, you describe it almost as apprenticing clinicians who finished their master's program and are awaiting their licensure. They work in clinics with licensed supervisors so that they get more patient experience and then serve as a pipeline to increase their mental health providers and their addiction service providers. They have a number of digital mental health tools that they describe, including online chat ability Monday through Friday during kind of working hours. They have 24/7 phone service that allows people to get connected to resources, including an on-call psychiatrist if needed. And they also have a number of different apps that are available on the website for all members. And those range from mindfulness and meditation apps to more specific one-on-one emotional support coaching, and then even an app which helps with goal setting and support for specific mental health issues like depression and anxiety. And then the collaborative care model is not specific to Kaiser. This is a model that many different providers are using, and it's embedding behavioral health experts into primary care or other clinics where they aren't, to kind of expand the ability of those primary care or other clinics to deal with behavioral health. So they usually have the primary care provider, a behavioral health care manager, and then virtually they have access to a psychiatrist to assist.
Dr. Schultz, just going back a little bit, when you say measuring the outcomes, what kind of outcomes would you be looking for? What kind of metrics would they have? 'Cause
so-
it seems like a little dicey.
It's not, behavioral health, I would say, is lagging a bit compared to physical health in having good metrics to track. But there is some movement to look at actual response to treatment. So for example, there is a HEDIS measure that looks at not only did you get a follow-up screen done for your depression, but did that score actually drop in a way that indicates that you're either in remission or response? So getting more data-driven.
Whether or not there's behavioral health medications being prescribed,
Yes,
whether they're going to visits, things like that.
yeah.
Yes, is this data coming from just claims, or would they look at EHR data and like see additionally like
Yeah.
what types of?
Yeah, so that first level, I think, is claims, and that's more process-based. And the goal, I think, for many people is to get to more outcome stuff. And in that case, you really do need to get into that EMR, which is a bit trickier for some of the plans to do and requires more partnering with the providers. And it's difficult sometimes even for the providers to extract that information, as we talked about earlier today. Interoperability is a bear in healthcare, and a lot of times different EMRs don't talk to each other, or different providers use different fields to enter things. So it's a work in progress.
Thank you.
Can you just clarify, what is EMR?
Oh, the electronic medical record. So instead of the paper chart.
Sometimes they call it electronic health record,
Yeah,
EHR.
EHR.
Yeah,
Yep.
it's- The middle letter is always interchangeable.
But not interoperable.
Exactly.
Seems good.
Well played. And then finally, Primera also again has similar approaches to try to expand their access. They have a homegrown service called Matchmaker, where they take into consideration patient preferences for what they're looking for a provider. And that they've had better success with some of the outside vendors they've used. They are quoting 55% of folks who actually get a match then actually follow up and make an appointment and see that provider. Roll that out to more members. They too are trying to actually just grow the number of folks that they have that are able to provide those services. It sounds like they've had probably a bit more challenge in the rural areas. They've had their growth mostly in the Puget Sound area. They also are approaching this by using virtual care options. They use doctor on demand and have a turnaround time of 4 days to see a psychiatrist through that platform. And then they too are working, as many different plans and providers are, with collaborative care. So they have a grant that they're working with UW in which they are piloting that this year, where they're embedding a behavioral health care manager and psychiatrist into a pediatric clinic that serves neurodiverse patients, and then medical oncology clinics that are in the Federal Way in Tacoma area. Next slide. And then this slide just summarizes where do members actually go to figure out what's covered in their plan. So step one would be going to your plan's webpage, and if you click through the services that are provided, you'll see behavioral health services link, and that takes you to these different options that I just described. When a member is new to the SEB program, that's a part of their enrollment guide as well. We have HCA, a newsletter that goes out to SEB members 3 times a year. Each newsletter does not have a behavioral health focus, but there's a repeating cadence of behavioral health focus with options for care. And then for both SEB and PEB members, there is a news page that is being finalized. That had been HCA News, it's going to be HCA Connection, and that's going to be rolling out this year as well. And that will have a behavioral health focus from time to time as well.
I just want to highlight on the behavioral health communications, they are constantly a work in progress. We had some member feedback earlier this fall during open enrollment, and we tried to make some changes real time to provide some more information and make some things available near the end of open enrollment. And this is just the beginning of some work group as we gear up for maybe trying to implementing some additional communications by the next open enrollment, because it is an area that is just needs some more elevation, needs extra space and prominence, because it just gets lost in a lot of the information that is out there. So we have some a work group that's kicking off internally to kind of look at our overall communication strategy and build on some of the momentum of some changes that we began during open last year.
Just a broad comment and sort of a curiosity around the focus on network adequacy, and at a provider level in the Spokane area, we've seen the big health systems sort of take the community mental health providers and sort of, they're helping to meet that network adequacy, but it's at the risk or at the expense of the Medicaid provider overall. So I'm just curious how the agency looks across these different sort of streams of how you have influence on the market. And then, you know, these are pretty awesome initiatives that they have, but that doesn't necessarily address from a full community view in that way. And, you know, I think where some of the previous conversations around licensure, there's a whole bunch of stuff. Personally, I think we could be doing a lot better to make access easier for lots of folks, but I'd be curious at some point if there's a little bit of like, how do those measures match up against the Medicaid measures, where there is no way in most Medicaid plans they're meeting a 10 and 15-day threshold, I would imagine.
It's a tough topic. You know, we have the Division of Behavioral Health within the agency. We've got our 5 managed care plans. We have our fee-for-service plan. We've got our SEB plans, our PEB plans, and to sit here and say they're all perfectly harmonized on what the plan is and how we're going to share the resources that are out there, that's not true. It's very difficult to do. Are we cognizant of it and trying to move in that direction? Yes, but it is difficult even to coordinate within the agency on how that's done, and especially because there might be different mechanisms with funding related to whether or not the legislature is pushing the button saying increase funding here but not over here, and that's a problem for us, or the federal government or whoever or whatever judicial branch is now doing their thing. I mean, there's a lot of moving parts, but yes, there is always an effort to make sure that we're trying not to rob Peter to pay Paul.
I think that just becomes an equity issue overall.
Absolutely. Other questions? Thank you both. Take your time. Melissa Richards, she's the benefit account section manager in the IRB division. She's gonna present some information on the open enrollment 24.
I am. So good morning, Chair McDermott and members of the board. And as
And I'm sorry, tab 5. Yep.
so as Lou mentioned, I'm here this morning to give you a brief overview of how open enrollment went. I'm sure you're all very curious. So the 2 primary units involved in open enrollment within the benefits account section are the customer service unit and the outreach and training unit. The customer service unit is the first line of contact for retirees and continuation members. Staff in our customer service unit, they have three primary functions that they perform. They answer calls via a toll-free line, respond to HCA support ticket requests. They provide in-person lobby services for walk-in members who may have questions about their coverage or forms. And then review members' retiree or continuation coverage eligibility as they process those. The outreach and training unit provides training and support to agencies and organizations for both the PEB and SEB programs, who in turn act as the first line of contact for their employees. So O&T provides training to the benefits administrator staff of these entities regarding program plan options, the covered benefits, eligibility, rules, and enrollment processes. When these agencies or organizations need additional assistance, they reach out to the outreach and training team through a dedicated toll-free line or a secure online correspondence tool called HCA support, as I mentioned. The outreach and training unit also supports the in-person benefits fairs that across the state of Washington during open enrollment. Benefits fairs are scheduled in-person events where an employee or retiree can learn about health plans and benefits. The dates, times, and locations are advertised in the October newsletter that gets sent out, as well as on our HCA website. Open enrollment readiness. So the customer service and outreach and training units work with other HCA divisions on open enrollment activities year round. Some of the examples are preparing our enrollment system, SEB My Account, previously SEB My Account, now it'll be Benefits 24/7. And then the outreach and training unit secures the vendors' locations and schedules for those in-person benefits fairs. We offered a pre-open enrollment training for benefit administrators in October to prepare them for open enrollment with any changes to expect. And then we also continue to work on the virtual benefits fairs. The VBF is an online website created with the same goal in mind as an in-person benefits fair. And some of the features are that they can learn about their benefits any time of day. They can access it from their computer, tablet, or smartphone. And then some carriers provide direct interactive webinars, pre-recorded webinars, and teleconferences to share plan-specific information. So we increased the communications during open enrollment this year based on the changes to premiums and benefits for the 2024 plan year. We sent out weekly notifications to members to remind them to review upcoming changes. Our first mailing was a postcard sent at the end of September to all members to alert them of changes to benefits and premiums. Our communications continued through open enrollment to include a premium increase letter, 4 postcards, and a benefits fairs mailer. Some additional communication strategies we had were we increased our social media posts. We had forwardable email messages, that were sent to the employers, which they in turn forward out to their employees with important information. There was an alert banner in SEB My Account, as well as the open enrollment web pages. And we had a website alert on the front of the hca.wa.gov, so members could easily find and go to the open enrollment web pages to view important changes. And then the October newsletter included call out information members need to be aware of when considering plans for 2024.
I just want to highlight we ended the last board season saying that we were going to push out and need to have more robust communication strategies than ever before to have as much engagement as possible for people who may not have engaged in the system. That was also particularly important in PEB, where many people have not looked at the system for decades. And so it was important on both sides of the house. I will say just anecdotally, I heard more people in the month of October, just as I interacted with them across government, say, I hear open enrollment is happening this year. So the message was getting out definitely more than ever before, just because casual conversations would bring up the fact that people realized open enrollment, and it became a joke that I would end various meetings across government with, don't forget to sign in to do open enrollment. And by October, then in October, people were ending the meeting that way for me. And other
Dave
parts
was persistent.
So I just wanted to say, we definitely, you will see that we have more engagement than we typically have had. But that was very purposeful. We had a commitment to do that, to try to make sure that people had an awareness. We kept the message simple about needing to engage because premiums and other benefit changes, and trying to have that just kind of permeate. And it seemed like that was fairly successful, so.
Oh, it was. It was the guess of, is it gonna be a postcard today or an email? today?
Or both.
Or both.
Or both.
Yes, definitely had days full. So some open enrollment highlights. Open enrollment was extended by 1 day due to a brief statewide Secure Access Washington login disruption. It was brief and it was in the middle of the day, and just as a reminder, SAW is actually managed by another state agency. So we made the decision to extend that open enrollment by a day.
Yeah, it was really unfortunate. The exact time, it was for like an hour, hour and a half, but it's historically in SEB, the last day of open enrollment between like 10 and 1 o'clock is the highest activity. And that 90-ish, 60, 90 minutes overlapped in that period. So we're definitely going one more day. So yeah,
It wasn't stressful.
that I think is Murphy's Law. So.
And as I mentioned in an earlier slide, we continue to offer the virtual benefits fairs. From October 30th through November 21st, there were 10,813 visits to the virtual benefits fairs. This option still continues to be the preferred method for employees who have questions about their plans. Last year, we hosted eight in-person benefits fairs across the state. And the 2022 fairs were the first year since COVID that we offered in-person fairs. We had a lot of lessons learned and applied those to the planning for this year. This year, we hosted 15 in-person fairs across the state. We used feedback from the fairs last year to determine location and structure, as well as the enrollment population data to determine the locations. The benefits fairs continue to be heavily attended primarily by retirees, which is what we saw in 2022 as well. Okay, that's the fun stuff. So now I'll go over some of the data we've all been. I saw some folks flipping to this slide already. I just wanted to make sure we're get there. So this slide is showing the changes from 2023 to 2024 based on open enrollment. You'll see on the first column there on the left, you'll see the full list of medical plans. And then in the next column are the total number of enrollment in 2023. And this is a snapshot in October, just prior to open enrollment beginning. And then in 2024, you see where folks ended up after the open enrollment period. So in the fourth column, you can see the change from enrollment from 23 to 24. I've highlighted in red the enrollment changes in each plan that actually saw a decrease from 2023 to 2024. I imagine some of you probably predicted some of this. So you can see some plans did have significant changes, such as Kaiser Permanente, Northwest 3. You can see a decrease of 1,342, or a 30.6% decrease in the overall. And just as a reminder, we do publish the switching report on our website each week during open enrollment. And then once open enrollment is complete, there'll be there's a final switching report that anybody can access.
Alyssa, I know that people are wanting to do the math in their heads because there was puts and takes. Some people left certain KP plans and went into others. Can you give us a ballpark overall number of folks who left the KP system in SEB? Can you do the math for us?
You know, math is not my strong suit, but I think I can get back to you if I plug together. I do on the next slide have some information about where people started and which plan they went into. So started in KP and then went to UMP. So I do have some of that. Yeah.
I do want to highlight on the prior slide, slide 7, that it is net changes. So there are people who moved, for example, from KP WA Core 3 into KP WA Core 2. So, or 2 to 1. So this is just showing the net of the pluses and minuses and all the switching. So there is internal pieces, and that's where some of Alyssa's subsequent slides will highlight some of the overall movement. But if you're trying to compare slide 7 with some numbers on 8 and 9, it's gonna be a little harder because you're seeing all switching on subsequent slides versus this is net switching. That just kind of rolls up what happened.
So this is a fun slide, and I do realize that there are not some of the little data tabs to show you the actual numbers, so I'll kind of go through this. One of the examples I wanted to point out was for KPWA Core 2. You can see the green bar that's going straight across to KPWA Core 1. So this bar is showing that 1,253 members who are enrolled in KPWA Core 2 moved over to KPWA Core 1 for 2024. Another example is the KPWA Option Summit PPO3. You can see the gray solid bar shows us that 1,223 members switched to the KPWA Option Summit PPO2, that plan. And then in UMP Achieve 1, the green line shows us that 746 members switched from UMP Achieve 1 to UMP Achieve 2. So this slide represents how many employees are switching medical plans with different deductibles. There was a total of 4,044 employees who were enrolled in a low deductible plan in 2023 who switched to a different plan. Of those 4,044 total employees, 1,258 of them switched plans but stayed in a low deductible plan. 2,123 went from a low deductible plan to a mid deductible plan, and 663 went from a low deductible plan to a high deductible plan. As I mentioned on a previous slide, the open enrollment switching reports are, they do get posted onto our website with more information, which is available to anybody that might be interested in these numbers.
Couple of other things just to highlight. So we did notice quite a bit of internal switching within a carrier. And when that happened, generally the trend was to a higher deductible, lower premium plan. That is generally the experience that was had, that many members had. I also can try to generally answer the question that Lou just asked, which was the overall switching. My number that I'm going to use is the subscriber or the employee, so the account. So it's just that life versus what Melissa has here, member lives. But for the subscriber, it was close to 11.5 to 12% of subscribers net switched out of Kaiser Washington within the SEB portfolio. And for Kaiser Northwest, it was about just under 7% switching out of the system. Those were actually lower numbers than relative to the PEP program. There was a higher volume of switching percentage wise that switched out within the PEP portfolio. So that should give you a little bit of a ballpark.
We have questions? There's no way to look at this data based on the classified versus certificated or income levels at this point yet, right?
Correct.
We're gonna get there.
Have there been any discussions with Kaiser? Like, here's the data. I mean, I don't know if there's like been informally starting to have discussions, or has there been a formal discussion?
I think it's a great question, Pam, to say. There was a very brief pause in conversations between the Healthcare Authority and Kaiser after the end of last season, but then we jumped right into conversations and have had a lot of leadership conversations that began in September and were occurring concurrent with open enrollment as well, about long-term strategy and collaborations. And then as open enrollment data has now kind of been finalized in late December, and now that the plan year started, we're going to be having more robust conversations about exactly how everything happened. We're all dissecting the data, looking at exactly who moved, what's the kind of demographics of who moved, and trying to identify some more information like that, and that will lead into the next rate setting season. So we haven't had on this specific switching, like the exact switching piece conversation, but we have had ongoing conversations between HCA and Kaiser. I think we took August off and then started to regroup.
January, February, a little rough with ledge season, so it normally starts
Oh,
in
absolutely.
earnest, pretty soon.
I'm just more curious. I almost want to say, told you so. Sorry.
I thought it would be more.
That's my informal discussion.
I thought it would be more, and when it came down to the final decision, just as my own example is that I had to compare if I stayed with this or went to this, the difference wasn't how much more I was paying for Kaiser. It was the difference between my Kaiser plan and the next plan that had the similar, and so I was only looking at a $28 cost adjustment as opposed to 74 to 115, so. Yeah, so I thought more would switch, but.
I will say this was like the year, because many of my friends and colleagues know that I serve here. And this is the first year they came into my portable and said, explain this to me, explain. And I said, well, I can't make a medical decision for you. I said, but I could walk you through a plan. And I said, what is best for your family? Look at the bill you paid this year. And there was more discussion than ever. So even though we all gritted our teeth with dramatic changes, maybe it was, in the end, it was a good thing that people started looking at what their plans were rather than renew. That we've done for so many years.
Ours was one of the recommendations I says, if you're planning on switching plans, start making some phone calls to find out if there's a doctor available for you to take out a UMP plan and move to that doctor. And our people were having a hard time finding doctors that were taking new patients. And so I'm not gonna say they were forced to stay with Kaiser, but that was a determining factor, is that they couldn't get into other plans because they weren't taking new patients.
Sort of an important point, isn't
Yeah,
it?
it was. I mean, I had multiple people who.
Might be cheaper, but if you can't see anyone, I guess it doesn't count much.
That's good that you asked me to do that, because that is important. And finding out when you have an issue coming up, like now I gotta go find a doc, is always much harder and much more stressful.
And I had people say to me that I don't like what I'm seeing, but I'm not giving up my doctor. It was that trust concern or issue. It's like, everything else is going up, this is going up too, but I know who I'm seeing and that has more value to me. And then they're like, appointments aren't, and nobody was getting them. Didn't matter what plan you were on, it was still forever to get them. So they're like, I know this frying pan, I don't know that one, so I'm staying with where I'm at.
That's why I think that helps give context to a lot of internal switching that was happening. You know, there was a very significant volume of people who switched plans within the Kaiser system and moved to a lower premium, higher deductible plan that stayed in the Kaiser system.
And it's because we're the lower paid employees. It's a large percentage of our pay. And so we had to make some tough decisions because of that, and it was hard. A lot of people work for their benefits, and now I can get the same benefits somewhere else.
The other activity data point that I have in my head was outside of the inaugural open enrollment where everybody had to engage. This was the highest engagement year that we've had within the SEB My Account system for activity. I believe we had, I remember asking, I can't remember which number was PEB and which was SEB, but I think in SEB it was double our high water mark for the prior years. And in PEB it was triple of our high water mark. So we had a lot more activity, which reinforced that our communication strategy was working. But I'm still concerned, you know, this is just around the time of year where people start to look at their paychecks. Right.
We're gonna get the
Correct.
first one to see.
Yes, you're in K-12, many paychecks are coming next week. In for state employees, many of them started last week. And people start getting their W-2s and then they start looking at all sorts of things. And so, you know, people are like, oh, how many appeals have you had? Well, we haven't really had appeals yet, because the part that people will really engage and realize if they miss or miss the communications and didn't engage is the paychecks that they're receiving in the next week. But we will have people who first check their paycheck in March or April, because every year we get appeals that involve the first time that somebody looked at a pay stub was March or April and realized something happened.
Other questions or comments for Alyssa? Alyssa, thank you. In an effort to get back on track, we're gonna bump the Smart Health. Kristen, thank you. I appreciate it. We're gonna bump that till March. We're gonna hear about our new platform that we switched over to, and
The good thing is we'll have more data about the initial engagement, because it was just like, it was barely like 2 weeks of data. And I told Kristen, I'm gonna go ahead and bump her from the PEB agenda, because I have a feeling the same time constraints will happen, that way she will have to come in person, only to have to come in person twice.
it's always about the right side. Yeah.
I used to be an optimistic person. SEB made me an optimistic person. Let's say that, I'm on the record.
All right, so we're gonna go ahead and take 10 minutes. Lunch is gonna be distributed, and then we'll start our presentations afterward. It is 12:06, let's go, 12:15, we'll call it 9, see? Before it was over, now we're under. Alright, we're back, we're eating our lunches and continue to eat, do your thing. But we're gonna have a presentation while we eat on benefits 24/7. Amanda, who's a senior business analyst in ETS, our enterprise services division, is gonna be providing some information regarding the 24/7 application that launched earlier this month. Amanda's materials are behind tab number 7. Hey Amanda, good to see you.
Hello, thank you all for having me today. So we're gonna talk about the launch of the new benefits 24/7 system. It did launch on last Tuesday, the 16th. We opened the front doors just right before 8 a.m. So we can go ahead and move to the next slide. One thing we did ahead of time is we closed SEBB account down, which was the previous platform for our SEBB employees to do their enrollment. It was closed down the week prior on January 9th. And we did that to allow any enrollment changes that were occurring during that week to be able to have time to get through our processing system and make it over to carrier that nature. So that all occurred last week, and in the last 10 days, I figured I'd bring some fun numbers just for your guys' awareness. We've had 981 benefits administrators log in since the first day. We've had 9,276 subscribers. Now that is not distinct just for SEBB. That is a combination of all of our PEB and SEB populations. But it's pretty significant for 10 days, especially in January at a time when it's not super busy. And I also wanted to talk about any issues that we maybe have faced because of course, a few minor hiccups have occurred in regards to the SEB population. On the first day, we were notified pretty quickly that the premiums were displaying incorrectly. They were showing the 2023 rates. The good news was it wasn't actually, impacting any paychecks or anything of that nature. And we were able to get that resolved and updated in benefits 24/7. I think it was about 5:40 p.m. that day. So we had a very quick turnaround on that. We've had a couple other small issues, nothing specific to SEB particularly. But one thing we did do pretty quickly with Dave's suggestion actually for our retirees to be able to jump in and provide them some additional links for premiums, just in case those are things that you guys have heard of. But no other serious issues with SEB that we've had reported so far. It's been great.
I went into the system, it's really slick. It looks really good, yeah.
How'd you get that? So we're just gonna kind of talk about some things that maybe you guys have already heard about, just kind of what changed from SEB accounts, some things that you'll find are the same. But some of the improvements we've had in benefits 24/7, very specific to our SEB organizations, is we updated first day of school and how that was reported. We've always had some issues with that in the past where maybe somebody didn't get in and update their first day of school in enough time and started adding new subscribers and coverage wasn't being granted the right day. So we made an update to that and it should be a lot more user friendly come September time. Another big thing that we were able to do by having all of the PEB and SEB population in one application was resolve dual enrollments real time. So we didn't have to have multi-day waits for that dual enrollment resolution or anything because everybody's in one application. we're able to communicate that real time and let people know if somebody is enrolled and be able to resolve that, which is wonderful. We also have a new portion in benefits 24/7 where our benefits administrators can go in and see actual history on subscriber accounts. So they can do some kind of self-discovery on maybe an issue that may have occurred or something, where employee comes to them and has questions about, why did I thought I waived my coverage and I didn't, and the benefits administrator can go in and look at that history and see if that did in fact happen or not before they have to come to HCA with questions. Another really cool feature, because we have PEB and SEB combined in one application, is our employees who are needing to go on to COBRA for unpaid leave, or they're going to retiree coverage, they can go and submit that request right in benefits 24/7. So they don't have to use a paper form anymore, which is really, really cool. We also made some enhancements to how the special open enrollment works. So if they have a qualifying event and need to make some changes to their coverage, we've made that a little bit more streamlined. There's also the visibility into our wellness program participants, which has never been available to our SEB program. We can see if somebody is qualified for that incentive or not in the previous year. We did remove the FSA and DCAP tile for the Navia because there is that new employer portal. However, we do still have those annual files available for benefits administrators for people who need their open enrollment elections into those programs. They can still grab those files from our data depot. And then also another issue that we seemed to have with SEB My Account was some locally eligible, that more small population of eligibility for the SEB program. We've made it way less difficult to incorrectly report that. So we have some steps that HCA staff have to take in order to be able to report somebody as newly eligible. So causing less issues with billing and
And for everyone who doesn't remember local eligibility, there is a provision of the original SEB law that allows for access, a district to provide access to benefits that are below the floor of eligibility in the PEP program. We call it 6E eligibility because that's what the statute is. And so people were being reported as locally eligible when they were in fact, it was based on SEB eligibility, and it was causing a lot of different work. So making that more difficult for people to accidentally, or a benefits administrator to accidentally report that really kind of takes away some manual cleanup processes that had to keep happening over the first couple of years of the program.
So this chart that you're seeing here outlines what really has changed for our actual members in the systems that they've been using. What you'll see here is that we had quite significant changes for our PEB population. And really for our SEB members, things are mostly staying the same, getting a little bit better, a little bit easier. The one significant change that, as I just mentioned in the last slide, was that now our members can submit those retiree requests or their continuation coverage requests right in the system without using paper. So that's our significant change for our SEB members here, as well as deferring retiree coverage as well, which is
I'll also highlight on this slide, one of the ways that the Benefits 24 system project began was the successful launch of SEB My Account. When SEB started, we knew that we were gonna have, 145,000 people who needed to make an initial election, did not want to have to rely on paper for that. Ended up having a homegrown enrollment system. I think we had somewhere between 98 and 99% of school employees who did their initial enrollments electronically. There was always that paper backup, and then the successful launch of the program with that new enrollment platform gave credibility and support to keeping much of the same team that launched SEB My Account intact for creating what ended up being called Benefits 24/7 and integrating the two programs on the back end so that those dual enrollments, for example, could be adjudicated. And really this is There were a lot of things you might remember in the early days where it was, here, you might need to leverage this from PEB. And a lot of times we were saying the word PEB in SEB meetings, and it was kind of SEB program maybe learning from the PEB program. And this was an example of the PEB program catching up and being advanced because of the work that happened in the K-12 world instead. So really excited several years later to be here on this front.
So just highlight some things that do remain the same for both our members and our benefits administrators. We still have to use Secure Access Washington to access the system, no change there. We still have a lot of reports that our benefit administrators can use to manage their benefits, although we have made some good enhancements to the reports the way they were in Set My Account. We have that data depot, like I mentioned, where we can deliver different data sets, W-2 files every year. That Navia file, like I mentioned. We also have that HCA support channel for our benefit administrators to contact the outreach and training program if they're having issues or need to work through, eligibility questions, things of that nature. So that's the same. The billing files haven't changed. They're still delivered every month within benefits 24/7, exactly the same way. We also have the opportunity for districts to upload an eligibility file. Typically that's used at the start of the school year when we have those more significant increases in hiring. That has not changed. And then the adding dependents and using that special open enrollment, those functions still exist in benefits 24/7. The great thing is mainly benefits 24/7 should just feel like it's a little bit of a SEB My Account facelift, I would say. Mostly the same, but just feels a little bit fresher and newer. So the dashboard for those benefits administrators, like I mentioned, really looks the same. We have that new tile for the subscriber history. We can see those changes that were made on the account. And in the special enrollment event, we did have a new section for account changes, which is more when somebody has something like a death or divorce that they need to report, or an address change. Things that aren't necessarily a qualifying life event that allow you to do significant changes. Those are qualifying, those are significant changes, but a little bit different than a special open enrollment. So that is new in benefits 24/7. Then I mentioned earlier that we have the new way of reporting first day of school. So we no longer are going to require benefits administrators to go into the system ahead of time to tell us what that designated day is. The nice thing about that is in the past, we've had districts go in and report that first day of school. And things come up where maybe those have to be delayed because of various reasons. And so in order to kind of counteract that and also just make it easier for our benefits administrators, instead of having to report a specific day, when they go to add that new subscriber, there's a checkbox that comes up. It will only come up in the month of September. They can hit that checkbox and it will give them their coverage, the coverage effective the same day that they start their employment. So a little easier to report that going forward.
We hear the beginning of the school year, it can be a little hectic, and so just one way of not having to have people go back and assist and report a different day. It's our way of helping out.
And that is something that I had many conversations with various benefits administrators across the state and got that feedback from them that would make things a little easier. So that was something we were able to implement in the new system. There has been some training along the way. This was provided by our outreach and training unit, but wanted to address that there was training. There's a actual training environment that our benefits administrators is still up and running and able to be used. So different than the actual environment where our subscribers are logging in, but allows them to play around and really get comfortable with using the system. There's also user manuals that exist on the benefits administrator websites for people to use and understand how to do things. Outreach and training has provided instructional instructional videos. There's also been recorded webinars. Many of those were previously last spring, April and May of 23. Then there was some pre-launch webinars that occurred in December. Further, they have an upcoming training next week. No, tomorrow. You can tell where my brain at. They have another training tomorrow after the launch of the system to kind of talk about, you know, how it's been going, any issues that people have been facing and things of that nature. So ongoing continued support for our benefits administrators. Feels like it should.
Next week is February.
Okay. There's also been a lot of communications and communication strategies around this new system. There's a helpful website that was launched on the day of Benefits 24/7 going live. There's quick start guides and postcards that have gone out this week. And then there will be an article in the February newsletter that comes out relatively shortly in regards to Benefits 24/7. And then for the benefits administrators specifically, there's been a lot of delivery messages in those trainings about what's going on with the project, and then that the project is actually going to launch. And then those launch webinars, the pre-launch webinars that occurred in December. So anybody have questions for me?
Questions? Thank you so much. Congratulations on going live and it working.
I'll just highlight for Terry and Allison, you saw the launch and retirement of my account. So, you know, now we're replacing ourselves right now.
Thank you so much. Next up, Ryan. Come on down, sir. Ryan Ramsdell, UMP team manager in the ERB division, is here to give us a debrief on the legislative report regarding the study on contracting for administration of the Uniform Medical Plan. The materials behind tab number 8. Ryan, welcome.
Thank you. This will be a little dense. So when you see the acronym TPA or third party administrator, I'm referencing regions for this purpose, and we're speaking to the Uniform Medical Plan. So in 2022, there was an engrossed substitute bill 5693 that directed our agency to study and report on the options for the possibility of transferring back administrative functions for the Uniform Medical Plan from its currently contracted third-party administrator back to HCA. Within that report, we were to provide some information around services, including what had been provided prior to the contract, 2010 and prior to that, procured through the third-party administration contract sense, and what elements of those services could be provided either directly or through discrete provider contracts if we were to take that work back, and the resources and the authority that the authority would have and need to administer those functions. So next slide. The report would have to compare the cost of the administration of components before and after the transition to the current contracts and include several components. Assumptions about the impacts on claims, description of the performance guarantees, and I can explain those at a later point. An implementation plan to enable the healthcare authority to resume self-administration for some or all of the administrative services at the end of the current contract. So I'll provide a little bit of background pre-2011. Next slide. Prior to 2011, HCA administered the provider network contracting in-house. That's the engagement with the facilities and the terms and the rates within all of that. But we did directly contract also with hospitals, health service providers, et cetera, in the state of Washington. But we did utilize a TPA at that time, which was UMR, or it was a United Healthcare company, to perform a lot of the other administrative tasks. And I'll spell some of those out because that's part of the report as well. So for UMP, next slide, please. UMP 2011 to current.
Because I see the computer changing over here. Yeah, I was confused. I was like, I really did go to the next slide. I swear. Are we on 5 now? This one, right?
We should be in 5, yeah, that one. Thank you.
Yeah, no problem.
In 2011, the Uniform Medical Plan Third-Party Administrator Contract consolidated all of the UMP Medical Administrative Services into one single contract, which we did award to Regents Blue Shield of Washington. When the 2011 UMP TPA contract was set to expire, and that was at the end of 2019, we did go out for a competitive procurement, and Regents was again awarded that UMP TPA contract for an initial term, which we're currently in 2020 to 2029. And there is a possible 7-year extension after 2029 that we can choose to execute. I want to also remind everyone that at that same time in 2020, we did take on the school employees population and they were eligible to participate in UMP. So that was a very large year.
One more piece that I'll just add on the background. So the contract, the original contract ended in 2019. We began preparing for a procurement in 2015. And so it is a very multi-year process with the data requirements, the integrations, and to make sure that it truly was an open and fair process where anyone could win. We had to start early. And so that also gets to, it might seem odd when Brian highlights that the current term goes through 2029 and could go to 2036. It's 2024. Where, some people have said, isn't this a bit early to have this conversation? In fact, it's right on time. And that's what the legislative staff had indicated, is they wanted to make sure that this report analysis was done, that if the legislature wanted to head in a different direction, that they had enough time to give the agency any instructions on that so that there could be a procurement, and that one would take multiple years. Some of you will also remember at the beginning of the SEB program, there was a question, could we do another procurement for a separate self-insured plan and UMP? And we talked about the inherent challenges of this very complicated procurement and how it wouldn't have produced, a different result than just leveraging the existing uniform medical plan. So if it seems like, why are we talking about this in 2024? Well, if we were to need to change direction for 2030, the agency would need to know that at the end of the next legislative session to avoid a lot of duplicative work and not fall behind schedule on a pivot if the legislature wanted to do that. So that's why, and we're also here giving you this report about this legislative report, because the budget provision says that the agency will do this with each of the boards the first meeting after it's turned in. And so that's also why we're here with Ryan describing it.
So we'll talk about now, what does the UMP TPA currently manage on our behalf? The current TPA contract for UMP consists of several of the following administrative services. So provider network contracting, and you've heard a little bit about that earlier today in regards to who we contract with to provide services. Process of claims administration, all the appeals that go on. Utilization, complex case, chronic condition, and quality management improvement. That's a mouthful. That's everything from the prospective, concurrent, and retrospective reviews that medical staff do on our behalf to make sure that service is provided appropriately and the costs are appropriate for the circumstance, and whether or not there's a need for those certain situations to receive different directions in terms of their care. So that's a large chunk of this. Additionally, the current TPA contract also is responsible for, and next slide please, medical drug management, member services, member communications and online services, fraud, waste, and abuse, and then operations and data reporting. So before I go on there, does anyone have any questions about that list? It seems like a small list, but it's a huge lift for Regents. All right, next slide. So scaling those efforts. The administrative costs for UMP represent 3% of the total annual costs of UMP, compared to what we pay approximately 1.8 billion in medical claims costs each year. UMP TPA contracts administrative costs are paid on a prescriber per month basis, meaning that the UMP TPA contractor is paid a monthly amount for each subscriber. And as of December 2023, more than half of all PEB and SEB members are enrolled in a UMP plan that amounts to about 387,000 out of roughly 675,000 UMP are PEB and SEB members. As a visual on the screen here, and this is contained within the report as well, is sort of a sense of the magnitude of claims versus administrative costs. And then on the right there, you can see within that sort of pie, those slices and the magnitude that amounts to the bulk of the services. So with the 3% of administrative costs, You'll note that utilization management and member services are the largest portion of the administrative cost, followed by provider network contracting and claims administration. So next slide, returning provider contracting to HCA. In order to perform this, we assess the feasibility of HCA providing some or all of the UMPTP administrative services and contract with Mercer Health and Benefits LLC to provide insights into current self-insurance industry practices and to analyze potential cost impacts. Mercer concluded that of the 8 administrative services in the current UMPTPA contract, the provider network contracting and the disabled dependent certification might reasonably be administered by HCA. If there's some question about that disabled dependent certification, that falls within one of those buckets, so it wasn't expressly spelled out, but those are 2 of the functions that they identified. Mercer concluded that the remaining administrative services would be best done by a TPA due to the high startup costs and efficiencies of scale. Some other considerations. In 2011, HCA transferred all of its existing provider contracts to regions to use in its provider network services on behalf of UMP. Due to the contractual terms, state procurement rules, and other legal barriers, the legacy HCA providers' contracts likely cannot be just transferred back to us. We can't just receive them back. We would likely have to execute new provider contracts, and that would include to be transferred back. New contracts may not be able to be secured with the same historical preferred discounts UMP experiences today, which would could potentially increase claims costs. Also, there's been significant hospital and provider network consolidation, including regional and several large national systems entering into the state since 2011. And with this consolidation comes larger providers who take up more of the market space, and in turn, it creates less market competition or makes negotiating a much more fraught proposition. So continuing on, slide 12, additional considerations. The current UMPTPA contract also contains numerous performance standards and guarantees, or PGs, that put more than a third of the total administrative cost at risk, with specific performance guarantees tied to provider network contracting, overall trend performance guarantee being the largest component. And I'll stop here for a minute and just sort of explain that a little bit more. Within our region's contract, we put certain guardrails around performance and expectation of our TPA. And if they are unable to meet those expectations, then the money that HCA pays to them for purpose of their administrative duties, portions of that are refunded back to the agency. It's a performance guarantee. And that can be anything from the way in which they manage the call center, to the way that they respond to appeals, to one that's pretty significant, which is trend management. And it gets a little bit technical, but it is an effort to sort of maintain the costs along a trend line that meets expected standards within sort of state, federal expectations, and the agency or their legislative expectations. So there's a lot going into that we might not have leveraged if it were brought in-house. It is assumed that if HCA did take direct contracting in-house, which was one of those 2 components that Mercer mentioned, we may have a pretty significant direct contracting disadvantage compared to TPA due to market share. Regents doesn't just manage our work, they have their own book of business and insurance products. Regents' staffing structure benefits from an economy of scale, as well as employees assuming the roles can work across benefit contracts and components with various employers. HCA may not benefit from a comparable economy of scale. This may result in an increase in staffing costs to the agency compared to the current Regents contract. So conclusions of the report.
So let's move to slide 14.
The report concluded HCA could assume some UMP administrative services that are currently provided by the UMP TPA contract, that being Regents. However, the likely increase in claims costs could far exceed any potential administrative cost savings. Maintaining the current UMP TPA contracted services and the established provider network contracting terms would continue substantial claim savings to the state and reasonable premiums for UMP members. The marketplace of third-party administrators already has existing infrastructure that allows it to scale with emerging innovations and establish partnerships that offer competitive advantages, thus providing greater combined purchasing power, ensure cost-effective compliance with federal and state insurance regulations, around licensure, provider directory, then credentialing, and certification requirements. I know that was a lot. I have one more component to the conclusion. These are considerations. So what I have to mention here is HCA was not asked to give our position or our opinion or which direction we think we should go, just to provide what would happen in the event that we were to execute their request. And so some important considerations is that clearly it's been mentioned that to take it in-house could have serious implications to claims and to benefits, or I should say premium impact. But there is an important consideration to consider here, which is related to forward thinking in the future of healthcare, the legislature's position in all this. If HCA did more direct administrative services of UMP, increased costs to the state might be offset as part of a broader health policy reform that can make accepting the claims increase an acceptable trade-off. If an overall systemic change was implemented, such as regulatory reforms around provider participation or contracting, it may be acceptable for HCA to leverage new in-house responsibilities to consider how provider contracting incentives and structure could help reinforce new value-based purchasing concepts as an example, and payment models within the commercial market. So, like I said, very dense. We did include an actual extract of the executive summary, as well as a link to the full report. Are there any questions?
I'll also plain talk that last slide 15, because I saw a couple people think, so if you look at just PEB and SEB in a silo and just look at the internal question of the cost efficiency for these programs, again, in a silo question boxed off by itself, you come to the conclusion of it probably isn't cost effective to transfer many things back into the healthcare authority. If, say, the legislature wants to move in a direction of a universal or a single payer system or something that really changes how the delivery system works, how we all experience health insurance in our state, in our country, then you might say, well, this is part of the grand give and take in moving to a completely different system. And so that's just an illustrative example of if you step outside of the PEB and SEB programs, you have other moving parts in the health delivery system, in the insurance world, and healthcare policy, you might say, yes, this will cost more over here, but it gets us this over there.
Has anyone proposed a potential kind of framework for changing the healthcare system? I mean, from the legislature or anywhere else, I mean, other than this study, but is anyone putting out a model that we might want to?
There are a couple of things that the state is doing. This agency, one of the other boards, we have about 14 boards, I think, that we support at the agency. And another one of them is the Universal Healthcare Commission, which is that I sit on that on behalf of as the agency representative, talking about what kind of iterative steps could be made in the state to move towards some sort of universal or single payer. This was a legislatively enacted commission. So that's an example of something. There is a bill. There are a couple of versions of bills that have had hearings in recent years that talk about, I believe it's called the Apple Health Trust is the name of it, talking about consolidating into that more universal system. And so there are a couple of different ideas that have been or are being evaluated. And that's where I think that was an important part for us to acknowledge in the report is, well, yes, you read this report from PEB and SEB, don't forget there's a broader conversation that is already happening. And that's kind of why we felt like we need to acknowledge that there could be a trade-off that a policymaker reasonably would want to make and say, yes, this costs more over here at PEB and SEB, but we're moving to something where we're not making those distinctions anymore.
Is the cascade care or the Medicaid or fee for service, does that factor? I mean, it feels like universal healthcare, I hope isn't a long way off. Feels a little longer off, but as we see some of these other programs come online, does that play into this assessment, or is that actually it's too different?
I think it could, and that's that broader legislative conversation about the health policy direction. That's why this report was challenging to answer the specific question, but acknowledge that there is this entire larger conversation that's happening right now. So I think it is something that kind of just is in the mix.
Other questions or comments for Ryan? And the report is available. Do we have the?
Yeah, there's a link that gets to the HCA website, as well as the executive summary is sent.
Thank you
So
very
if I
much.
have insomnia, this report will be a good one.
I'm rushing home to read it.
It's actually very interesting. It's not excessively long.
Well, okay.
So, all
It's very.
right, thank you.
Thank you, Brian.
Somebody's in the right job.
Well.
All right, next up.
Someone who else write it.
Next up, we have Tanya Dool and Kate Walker. We're gonna go over the governor's supplemental budget and lynch season so far. Materials are behind tab number 9. Hey, folks.
Hi, everyone. Hi. I feel like we were just here. It's been a half year, right? 6 months, but I feel like we were just here doing rights.
It's almost exactly 6 months.
Yeah.
Does not feel like 6 months.
All right, well, my presentation will be quicker than it was this spring. I just have a really quick update on the governor's supplemental budget update, which came out last month. Next slide, please. So just as a refresher, what the supplemental budget really focuses on is really that second year within the biennium. So it's gonna work on making any refinements to the funding rate for the school year 24-25 year, as well as any benefits or changes that we would consider for plan year 2025. So we're already in 24, we can't make changes, so this would be any considerations for plan year 2025. And one thing that I'd like to bring up is that supplemental budget, we really try to focus on smaller refining things, not large policy changes or big programmatic changes. Those for the PEB and the SEB program are really reserved for a biennial budget for that longer session and for those biennial budget considerations. So for that reason, this year HCA leadership decided to focus on 2 real different decision packages. The first one being an alignment decision package. And when I talk about alignment, I mean alignment whether between PEB and SEB or alignment between our fully insured and self-insured carriers. So that alignment decision package had one item for the SEB program, which was related to breast exam screenings. And this is a result of a bill that had passed last section. It was Senate Bill 5396. And this bill eliminated cost sharing for diagnostic and supplemental breast exams for the fully insured plans. So the Primera and the Kaiser plans within the SEB program, but it did not address UMP. So part of that alignment decision package was to bring in alignment, the self-insured uniform medical plan, and remove that cost sharing equally. The 2 other pieces that were part of that decision package are really in the PEP program. That first one being aligning vision. So in the SEB program, we are going to be increasing the hardware allowance for calendar year 2025 by $50. And so we thought it was appropriate to try and, in the words of Dave, pick up that rock.
We're already picking up the vision rock. So
We're picking
while
up
we're
the
picking
vision
it up,
rock, so we're gonna try and pick that up in the PEP program too, so that there's alignment between the 2 programs and we could implement it at the same time. And then the last item within that decision package was the diabetes management program that was funded within the SEB program in the last budget, just aligning that in the PEP program. As you can imagine, the management of our diabetes is really important, and having that alignment between the PEP and the SEB program is really, really important.
and that
So-
diabetes management program for SEB and Uniform Medical Plan went live 26 days ago. So it's a benefit that exists in UMP for SEB, but doesn't exist currently in UMP.
So the number here for the breast exam screenings is really half of a fiscal year's worth of cost, because it will start on the calendar year January 1 start date. So the full year's expenditures are actually that are shown on the screen. And then my last slide, I told you this would be. Yeah, so the numbers shown on the screen are the budgeted amount, which is based on a fiscal year. We do budget on a fiscal year, but we make benefit changes typically on a calendar year. So because this would start on a January 1st start date, this is 6 months worth of a fiscal year. So
Fiscal year's July 1st. through
July
June
1st.
30th. Yeah, which always has been a challenge with our plans, our calendar year, the budget is fiscal year. and
SEB
so-
has a school year, which is even more
Yeah, which is
years.
even more wacky.
That's a whole different cycle. So yeah, this would be 440,000 in the ongoing years for a full 12 months. Next up are the funding rates. So the 1100 funding rate on the screen is for the current school year that we're in. And then the 1197 is the funding rate that's included in the governor's budget. These are paid on per eligible employee basis per month, regardless of how an employee chooses to enroll in their medical benefits. They could waive, they could enroll 5 children, they could pick a really expensive plan, or they could pick a cheaper plan. This amount is paid regardless of how an employee chooses to enroll. And I will say that because this is based on the governor's budget, we will deliver another quarterly model update to the legislature prior to settling the final conference budget. So the final conference budget numbers could change from either the decisions packages that I included or this funding rate, because we will refine our claims experience and our enrollment assumptions, our trend projections, and all of those components that build up to the funding rate. We will deliver another quarterly model to the legislature before they settle on the final conference budget. So this will be possibly a number that could change the next time I'm in front of you.
In fact, this is where Tanya or I say, there is no magic number. And that's where Tanya often comes back and says, Stephen's like, the number that's in the budget is adequate to maintain current benefits. And because there's a lot of different assumptions that just go in that number. So it was, I would say odds are the number will not be the same in the final legislative budget. I don't think any year they have ever been maintained after the quarterly update.
One large example would be the results of switching, and numbers that we walked through a few presentations ago where we showed how many members switched from which plan to which. The model that was used to develop the governor's budget did not include the results of switching yet from open enrollment. The model we will deliver to the legislature in the next couple of days will include the switching results. So that's one lever, but there are a ton of levers that change every quarter. So this number could definitely change by then. It is like, because you pop one and the other one pops up.
You just say there's no magic number. It's easier to say no magic number, there's not a specific number.
So that's it.
No.
Well, you can provide. We're usually a duo with this.
You just kick her out. That's
No, shame. She said, do you want to stay on? I'm like, no, I mean, it's great, it makes me look better. Because I don't know the numbers so much, but, yeah. Well, I avoid numbers like all good lawyers.
Not bill numbers.
Yeah, well, I try to avoid them, they just get garbly. All right, good afternoon, everyone. Kate Walker, Section Manager for the Policy Rules and Compliance Section within the Employee Retiree Benefits Division. One of the good things I have in that new role is I maintain all of the work that I've done for the last several years for the division on the legislative front. So I continue working and managing that process with all of our division analysts and helping to coordinate just our process. Just to give you a sense of what that is for new members and also just as a refresher, because there's a lot of work that goes into this session. And we start getting ready for the session in the fall. We start doing trainings, we start making sure we're revising our processes. We have about 35 analysts within the division that have other, this is part of their other duties as assigned, where they have their full-time responsibilities. A lot of them are here attending. Then when legislative session comes around, they have more responsibilities that they're going to be doing analyses on bills that come in as they get introduced and might have impacts. And then they go through a lifelong analytical process of reviewing the legislation, reviewing it with an equity lens, reviewing it with a fiscal lens, reviewing it with a policy lens, saying how is this going to impact what the program does and what we do and how we serve our members. And they write all that down and it goes through a big review process. And then it goes up to the agency and then it goes out the door for comment to either leg staff or legislators. And that's kind of our process. So I help manage that process for the division and help make sure that if there's things that need to be brought to Dave's attention or to the agency's legislative leadership's attention, that's what I help do. So that's why I get to come and present on this, because I'm trying to help be that nexus point where a lot of things get fun. So that being said, we'll dive in. On the first page, actually, I get to skip this nicely because Ryan did a great job. We're talking about this a lot more in depth. I just wanted to make sure that it was included in my presentation, just as I know that there are people that go back and look at these presentations like I did to see what did I talk about last year and reported and just give a brief synopsis of that much longer presentation that Ryan gave. So we go to the next report, we have the PEB retiree Medicare benefits report, which I think there's also more presentation on that or is it wrap?
Oh, there's a little bit, but
yeah. So we submitted to the legislature the PEB retiree Medicare report, which was part of last year's budget to require us to submit a report that looked at the member feedback and providing analysis about PEB retiree benefits. I know that this is the SEB board, but eventually, and I think hopefully all the members eventually get into the state of retirement. I think that's the thing we're all working for. I think some are closer than others. I'm not sure where.
It's.
I'm thinking about
Getting voted off the island.
So it was an analysis to look at that. We held a whole lot of listening sessions last year, which is another part of the aspect that we realized having someone who has a job responsibility of doing stakeholder and community engagements was so critical, because we had gone and done, was it close to 20 or so listening sessions with 24. Again, Dave's a number person even for being a lawyer. Listening sessions between February and May of last year, 193 participants, those 24. So they were pretty intimate listening sessions and real frank conversations with retirees to get their feedback and have some opportunities for those retirees to talk directly with the program and provide input that was then put into the report. It also required looking at 50 state, kind of a full circumspect look at what 50 states are doing in regards to retiree coverage. And I think one of the key things that was found from that is that the benefits offered to the retirees in Washington are just far richer than offered than most of the states out there. So kudos to Washington for retirees. It can always be better, but it's worth noting that it's look at comparatively to the other 50 states, it's ranks in the very top. Last, provided some alternatives for retiree premium savings that could come about related to pharmacy and medical coverage changes to the plans, which was one of the directives from the legislature to the report. So that report is available on the website under the HCA legislative reports if you're interested in reading that and having a good something to read if you're struggling to sleep at night, just like that community report.
That one is also equally interesting. All of our reports this time are very interesting.
Yes. And last, and not one that ERB had as much of a role in drafting, we were a participant in it, but I did mention it last year, so just wanted to bring it to conclusion. There was a report that was submitted to the legislature earlier or middle of last year regarding fertility benefits, mandatory fertility benefits. This comes after a sunrise review that was conducted by Department of Health about what should commercial coverage entail for infertility or fertility treatments. And so that report's been turned in. I've included the cost estimates because I think when we're thinking legislatively, there's always a really good emphasis on the policy side, but I think equally important, a lot of the things that we deal with is what are those cost implications that go along with it to kind of see, well, is that number going to be something that seems like that policy is going to be able to move through balancing the policy and the cost implications of that. I think is a nice little indicator of where the legislature might find themselves at with implementing or moving legislation forward in the future based on any of our reports. So with that, I'll just move right into where we're at so far this year. This year's a kind of a fun one because I'm only going to be able to speak with you once in person before session's over because it's happening real quickly. We started on the 10th of January, 10th of January, 8th of January, and we'll be done the 9th of March. It's a 60-day session, it's a short session, it's the end of this legislative term. And the cutoffs come faster than ever. The first cutoff, the first policy cutoff, which is when the legislation needs to have made it far enough in the process of that wonderful how a bill becomes law that we get from Schoolhouse Rock, and needs to make it past that first policy committee by the 31st in order for it to still be alive. Because I guess like a corporation, we give it its designation as being like a person and has life to it. If it doesn't make it past that policy cutoff, then it's dead. And because it's the short session at the end of the legislative term, then that's going to be done for moving forward, and it'll have to be reintroduced in the future terms if they want to have the legislation forward. So all that just kind of contextual for where we're at in the session. So it's been a busy one so far. And I want to pause and any questions.
About the zombie bills, but I think that wants to run out of.
Oh, so what we've done so far, and this is actually adjusted nicely since I had to turn this in to make sure it got published. That's where I'm the slowest person on everyone's presentations that get turned in because I'm waiting till like literally the hour before Jessica is going to come and beat me over the head, say, get your presentation in so we can get it reviewed and put on the website. So I have the numbers have even moved beyond from this, but this just gives you kind of an idea of how much work that we're doing. And we've had a total of 46 bill analyses. I think we're actually up to about into the 70s of bill analyses where we've taken a look at legislation and had an analyst go through and there's a whole slew of questions we have. It's about a 4-page template that starts out about 4 pages. And usually by the time the analysts are done, it can be anywhere from 4 or 5 up to 10, 15 pages, depending how much additional information that needs to be added to provide a thorough analysis of that legislation. So there's a lot of work that goes into this, and that's why I like to include this because it just kind of evidences the amount of work. Now we break up the bills that we review into different categories. We have the agency will determine who is supposed to be the lead division and who's supposed to be the support divisions. And they're going to assign the lead division based on kind of their impression of the legislation about whose division is going to have the best or the most impacts from that piece of legislation. For instance, an easy way to say is if it's a Medicaid and Apple Health focused bill, they're not going to assign it to ERB to be the employer commercial purchaser. So we wouldn't get that. A lot of things that are changing benefits kind of in the system as a whole. It'll go to our clinical care and quality transfer, clinical quality and care transformation team with our clinicians, having them review those. We'll get all the bills that are really focused on what's changing on the commercial insurance market, what's changing, what things are directly at SEB or PEB, whether it's eligibility, things that relate to retirement. We'll get a lot of those bills assigned to us. And we'll prioritize those more because we're now the lead. We have to collect all the feedback from other divisions to include that into our analysis. Then we'll divide it, once we've been assigned either the lead or a support, then we'll divide it further into a high priority or a low priority. The high priority and low priority designation is really just one little bar that we have to say, do we want to keep a closer eye on this because it's going to have some pretty good impacts on what we do. Those impacts might be things like our rules or policies. We need to go into our Washington Administrative Code and change up our rules or policies that we have, which requires a good amount of work. It's about an 18-month process for us to change any of our rules or policies. Or we'll also designate bills that have a significant fiscal impact, which we determine as, or we state as $50,000 or more, which is actually a really small amount for anything in our programs because any sort of benefit change that might happen, it's likely going to have more than $50,000. So if it's changing anything, like a good example, the insulin bill of changing the copay to be no more than $35, that was going to have more than $50,000. Not, how much more than that, it's really going to depend on Tanya and her team in making that determination. But if we see something that's going to have more than $50,000, we'll call it a high priority. So that's our breakdown of the bills we have for the grand total so far of 46 as of last week. We're up to about 7 so far. I also just want to note, fiscal notes are a wonderful added layer to our analysis process where not only do we then have to do a policy analysis of the legislation, but now we have to involve finance and incorporate have a whole other overlay of a fiscal analysis gets done that says, what's this going to cost? If we implement it as is and what the language says in the bill, what is this going to cost us? What is going to cost what program to implement this? And for ERB, we work heavily or very closely with Tanya and her team to provide her here's what this bill is doing. And then they're able to take that information and cost that out. They'll work with the carriers. If it's things that are changing benefits, if it's something they're requiring us to do a report, we're going to get some estimates on what we're going to need from maybe a contractor or an FTE to do that report. And then they'll include that in the overall fiscal notes ended up. So it's a lot of work and also accelerates our timeline because our turnaround in all these bill analysis is about 3 days. We get a fiscal note, it's about 1 day because then we need time to have that fiscal note. And all this is trying to get feedback in time before bills are heard by committees or executive session. So we're wanting to try and provide that useful feedback to legislators if there's something that's happening in the legislation that is either going to, it's an impossibility, or we want to make sure that it's noting costs because we want them to be able to weigh the policy implications and the financial implications when they're making their decisions. So all this has a timing aspect that's really critical, which is why I spent a lot of time during this session gearing up for and then making sure that we're moving everything through to get that feedback. Okay, so then with that, we'll move to the funnel effect to show the progress of legislation. And this is outdated already within a week, and I will speak a little bit to the bills I'll highlight. But this is just the no help on the right side showing what bills have moved into what aspect of policy chambers or the different committees that it has to pass through. But it does at least show you the cutoff dates. So that first date on the left, January 31st, that's the cutoff date for the origin, the chamber of origin for a policy cutoff. That's all the committees that aren't the finance committees, meaning it's not Ways or Means or House Appropriations. So every other committee, the legislation has to be passed out of that original committee by the 31st in order for it to continue being alive. Since it's a zombie bill, but that's it. We won't talk about those ones. We'll leave that to AMC. Then we'll have the fiscal cutoff on the 5th, which is just a few days after that, on Monday after next Wednesday. And then you see those cutoffs that move all the way through to the 1st, where it's got to be off the floor, and then to the governors for signature by March 7th, being the signed last day of session, pending they go into extra meetings if they can't get to an agreement on the budget, which is usually. But what not they don't usually go into extra sessions, but if they're going to go into extra sessions, it's probably because of the budget. And little initiatives might cause it. I guess we'll see. That's going to be an interesting one. Those initiatives that are making their way through are going to be an interesting. We haven't seen those before. So.
Next slide.
Next slide. I spent a lot of time in this world of things, and I
A
just
lot of time on that.
yeah,
A lot of meeting there.
all those number soup and legislative soup. All right, so let's talk about actual bills, things that are happening. First things first. We did have a piece of really exciting agency request legislation that came out of our program this year. And by really exciting, I mean, it's like our reports where if you want to go through and read it, it'll be a great way to replace your Ambien or Lunesta at night. Senate Bill 6094, and this is literally the title. This is the short title of it. I'm not even joking. They call this the short title. Aligning statutory language concerning the retired state employee and retired or disabled school employee health insurance subsidy with the historical interpretation and implementation of relevant subsidy language in the operating budget. I think that's actually longer than the language in the bill itself. I think that's actually correct.
So I will say Kate's given me the challenge, and anytime I see a bill with a longer title, I send it to him.
Which makes for a fun way. We review a lot of legislation, you might as well find little fun things about it. Makes it fun to say a word. So that's the short title, sponsored by Senator Robinson. Much appreciation to her for sponsoring this legislation. What it's doing in a real brief nutshell of it, it's cleaning up the differences between longly held budgetary language and statutory language regarding the explicit subsidy for the PEB Medicare plans. It's what has been put and operationalized in the budget, which is what's constantly, every year they're amending that budget, the bill number where that budget lives statutorily, and then the language we have in 4105 that speaks to the explicit subsidy. It's making sure that those are in alignment so that the practices and the way that the legislature has provided funding for the subsidy now aligns, or that the way that has customarily and longstanding been put into budget will now be aligned with what is in this, which is what's in the statute. And I'm probably saying that terribly because I'm occupied on something else. David, is there any further clarification or insights you can provide on that?
It's really, the statute uses the phrase refers to prescription drugs and seems to suggest that the subsidy is about only the drug coverage within the plans, whereas the budget language refers to health plans, which is medical and pharmacy. And so it's just taking that phrase and being very clear that since the subsidy has existed, the agency, the interpretation and understanding and implementation by everyone from legislative staff to the agency has been that we look at the total cost of the plan, not just the pharmacy cost of the plan, and apply the subsidy to the total cost of that plan. And so as we were looking at, been spending a lot of time in retiree work, we thought, well, we should make that clear in the statute, because the statute is the permanent state law, and the budget language has to be renewed all the time, and it's just best practice to have those better aligned. So boring, a little bit.
And importantly, as I note here, it does not eliminate, it does not limit or otherwise add or change any of the plan choices or plan designs, nor does it change the board's plan offering authority for the PEB Medicare plans. So it's because it's a little convoluted in what it's doing, there's always that worry that people are going to assume that it's trying to do more than what it's actually doing. But really, it's just that alignment of the practice and the way the budget has always come about for as long as I've been able to go back and look at budgetary language, that it just didn't align perfectly with the way we've since kind of evolved with our terminology that we use over the last 30 years since the language initially that was in statute was put in there to align that. That bill is currently in the Senate Ways and Means, it passed now into rules. So it's kind of moved forward quite a bit on that funnel. It's now third tier of that funnel, the originating house, the originating chamber. So moving on to some more of the topical things. SEBB program, we have House Bill 2125 concerning eligibility for contingent faculty at community and technical colleges. This bill is currently sitting in appropriation, so we know it's moved past the first cutoff. this is providing a little bit of an expanded alignment of the definition and ability for the part-time or the staff and faculty at technical and community colleges, the hours they work that are not just teaching hour classroom requirements. There's some trickier, complicated eligibility, and it's not germane on the SEB side because we have SEB eligibility. But for technical and community colleges, based on the different faculty, different hours and stacking they have between different community colleges, it's to be very, very convoluted. This is helping to expand that some of the hours that are worked by those employees that may not otherwise be considered by the community colleges as being the type of hours that should count towards their benefits, that those hours should count. Kind of similar to in the SEB program, counting holiday hours and paid leave hours towards eligibility. It's a very similar concept about legislation on the community and technical college side. Looking at retirees, we've got a couple of things going on with retirees this session. First, House Bill 2013. This is legislation that was introduced last year from DRS regarding the month of death for DRS payments. This is legislation that would say to DRS, or requires DRS, that when a retiree who's receiving benefits through a DRS plan, whether it's TERS, PERS, SERS, 1, 2, or 3, or if you're Connie Bergener, I think she was on PERS 0 or PERS. In the month of death, what normally happens is the DRS will do a clawback of that amount, prorate it, and send it back to the decedent's family, or whoever would receive that otherwise. The effect of that has been, for a lot of it, it's from DRS perspective, not cost too much issue, but for us on the benefit side, it causes a pretty significant problem for them because they will claw back that payment. A lot of the retirees have automatic payments that are deducted from their DRS payment directly to us, so that they has their benefits paid directly to us and has their coverage done. But on that last month of death, DRS claws back that payment to then send the prorated amount to the family. And that ends up having an unpaid balance on that account. And that last month for the retiree probably need that coverage. And so HCA, our accounting team, will reach out and then try and get the payment from the decedent's family or their estate to have that money come back. And sometimes it can take a while, and it can be a little more complicated. Sometimes, there can be complications that arise, and if there's surviving dependents or surviving spouse on the account, there can be some gaps until everything gets sorted out payment-wise. And so the thinking from DRS and now with some of our input and support was that they want to have that whole month of death benefit be paid in its entirety, not prorated, so that then they're not having to worry about claw back that amount from us, and make it so that for that time when it's a struggle of a time for any family having a loved one pass away, that we ease that burden for them regarding that complications of payments for their health insurance at that time that they pass.
What's the fiscal note on that?
That's a really great question. It's pretty high, and it'd be fun to, I think it's up there. Dave, you probably know the number.
Yeah, I'll add a little bit more context there. It's actually like $5.4 million in the pension funds. And remember, like the PEB and SEB programs combined is $5 billion annually.
Yeah, no, that doesn't sound like that.
Pension plans is bigger than the $5 billion of these programs. So it's in the grand scheme of $5.4 million is a lot of money. In the context of multi-billion-dollar pension and health benefits, it's a small amount of that.
Sure.
I do want to highlight that 2013 isn't just about PEB retirees. There are other implications that DRS really highlights are profound impacts. For the PEB program, we're talking about, we have about roughly on any given day, 100 accounts that are in this limbo status for either the decedent's last month of coverage or their surviving dependents that might be in flux and transitioning to their own account within our system. But on the pension side, they're talking 500, 600,000 individuals annually that they are working on some sort of issue, or I might be thinking that that's not an annual, that might be been a 10-year projection that needed to be brought down to a year. But it's a significantly larger number than the 100 accounts that are in the PEB program. There are also implications. So what happens in the month of death is that DRS does have to pull back the payment from the bank account, as well as the pension deduct payment for us for those individuals who pay our PEB premium. But there are collateral effects as anyone who is dealing with grief and finances and bureaucracy all at the same time, not a good combination. And so to have money clawed back and then, DRS is having to do a pension calculation that is unique to that individual, and could it be different on any of the 365 days of the year? It's just a very complicated system. And many times there is a personal representative that doesn't know or interact with the public sector much. On the healthcare side, they don't know what PEB is. They don't know what HCA is. They expect maybe Regents is supposed to call them. I thought my mom had Regents. And so there's just, I thought I paid the premium. Here's a deduction. I see it on a pay stub or on a bill that I got from the Department of Retirement Systems. Are you telling me that I owe money? Why would I want this? I thought Medicare covers everything, and not understanding the supplemental aspects of all these plans. So it's just a really complicated system. The health side is very natural for people to latch onto and understand the complicated aspects of it. But think about a firefighter or a police officer whose family is dealing with that grief. And then all of a sudden there's this weird financial aspect that's happening in their bank account that has nothing to do with PEB. It's everything related to the pension and financial security that they have. And so the 2013 is a much bigger bill than the PEB side. And the reason I bring this up, sorry, I'm going to steal this one from you, Gabe. There's another bill that was introduced today that is related to, but addresses this problem differently. And it's House Bill 2481. And that is a bill designed specifically to address the PEB insurance issue, subset of the issue that exists within 2013. And that new bill would simply waive premium in the month of death for the decedent, and then transition coverage for the survivors of that account and have them pay premium as of the month of death going forward. But it would be a waiver of premium. There are two ways to solve the PEB insurance problem. 2013 does it by saying full month of payment. There would be no clawback. There would be no limbo that would ever happen. 2481 does it by saying no premium is owed. So there's two different ways that's being looked at, but the PEB specific 2481 is only a subset of the issue that DRS and the Select Committee on Pension are trying to resolve with 2013.
And out of curiosity, does the agency weigh in on both of them?
We support both answers that could solve the problem. So.
Yeah. Somebody else gets to make the
And
decision.
yeah, they are not mutually exclusive ideas. They both could pass. There could be, we'll keep a move to a full pension payment under 2013 and a waiver of premium in the month of death under 2481. So they are not mutually exclusive ideas.
Oh, yeah, one directly solves the issue, one indirectly solves it. And both get there and they're not exclusive. At 2481, waiving health benefit premiums in the public employees benefit. And we didn't get on here because we were asked to draft it last week. And so it's sometimes that's what happens, and we get asked, here's a problem, if you can help put some legislation together in, 24 hours, as opposed to 6, 8, 9 month cycle that sometimes we get to write things and we can turn something around. We've got some really, really smart people on the team that gets to put in. And so it's fun to see like, oh, that's a pretty quick turnaround. Drafted it, a day and got it introduced today. It's in approps and we'll see where it goes.
But just to be clear for the record, we were always and still are supportive of 2013, and a new bill existed because we were asked to provide support for an alternative solution. It's very important that everyone understand that this agency very much supports DRS in 2013 and equally believes that that is an answer to both this problem and broader problems with that happened with a month of death.
We get asked to help write legislation because we're the technical experts on our statutes and our rules and policies. And so we get asked a lot to review things and say, make sure this works for your rules, which for anyone listening that's writing legislation that impacts us, don't be afraid to ask us to take a gander at it, because then we can help make sure that the impact you're wanting it to have is having it in the right way with our rules, and it finds its way into our statutes the right way. We're policy wonks, we can kind of take that policy approach, which isn't should or shouldn't pass. It's if you want this, here's how you get there. Help do that because my team, they know those rules forwards and backwards. They really are the subject matter experts on it. Really proud of those folks. Okay, the last one for retirees, House Bill 2188 and Senate Bill 6139. This is changing the health insurance subsidy rate for retired state employees and retired or disabled school employees. This is changing the subsidized amount for plans from it's the 183 or 50% of the planned premium, and it's raising that 50% to 60% for the planned premium for retirees. So providing more funds for the plans for Medicare retirees, for state retirees that come from either the SEB or the PEB programs.
Explain what that subsidy does, how does that affect the person?
So a Medicare enrollee, we look at the, it's, we calculate the, Tanya, do you?
Yes.
Yes.
I'm just gonna say the wrong word. I was like, am I supposed to say rate? Am I supposed to say mid rate? Like,
Save money, less premiums paid by the
I
retired.
was already standing.
So that's posted as the premium they pay, and that subsidy is already built into that premium for the year.
So similar to how the SEB employees, we look at a total bid rate and then there's an employer contribution and then the rest is the premium paid by the employee. On the Medicare side, there's what's called a Medicare explicit subsidy and it has a cap that is set in the budget that is currently set at 183 or 50% of the premium, whichever is less. So we take the bid rate and then we subtract that Medicare explicit subsidy. So either $183 or 50%, depending on the size of the bid rate, and the rest is the Medicare premium. So what Kate's referring to is increasing the 50% lever to 60%, because that doesn't live in the budget bill like the cap of 183 does. It's in a separate place. They're kind of de-linked in the bill, but the governor's budget takes care of the 183 to 93, and then this takes care of the 50% to 60. So both of those are increasing. So we'll see what happens in the final conference budget. Does that work? Okay. You're welcome.
Just stay.
Yeah. I don't know, the next one don't have as much,
But still, just
yeah. Please stay, your presence. All right, moving on. Some of the other topical areas I always think are germane for the boards to know are where there's aspects of changes to or potential changes to medical costs that are shared between the member or plan. House Bill 1957, preserving coverage for preventative services without cost sharing. This doesn't have any actual impact over the status quo. What it's doing is codifying in state statute, federal statute from the Affordable Care Act regarding essential health benefits. So this is Washington's effort to say, hey, look, we see what's happening with the courts on the federal side, and there are components of the ACA that we want to have codified in state statute to require the carriers in the state to follow the same things that they're currently required to follow according to federal regulations. So this is taking the components of the Affordable Care Act that relate to essential health benefits, and those benefits that are added to that essential health list that all plans must cover to be qualified, QA to qualified health plan under federal regulation to be offered under exchange, which all of our plans that we offer under PEB and SEB also meet that, except for the high deductible plans. That it would codify that, and it just has some timing requirements there about when they would be required, but it is almost word for word the same as what's in the federal legislation. And so we'll continue to track that, because if that does get repealed, then we know that now we have that legislation that will have that impact, preserving the requirements of those essential health benefits as defined and categorized by some of the associations that are used to add new essential or just current essential health benefits on the national level, like the USPSTF and some of those other organizations. And we have House Bill 2285, which actually doesn't look like it's moving, but Senate Bill 5986 is what's moving, and it's currently in Ways and Means, protecting consumers from out-of-network healthcare service charges. More consumer protection regarding out-of-network charges for consumers. Expanding on some of the recent legislation that's been passed that had granted protections or helped to assure that when members receive services at out-of-network facilities in which they had no real ability to control the services they receive, kind of like the anesthesiologist, when you get that giant anesthesiologist where you're like, well, I don't remember, I didn't have a choice, I was getting put under it. Help adding more preventions or protections around how the out-of-network service charges are to be handled for individuals who are covered by commercial insurance. And we have on the pharmacy side, always a lot of interest in what's going on pharmacy-wide, both from legislature and I think from the boards. There is a House Bill 1884 and Senate Bill 5814 regarding coverage of prescription drugs for advanced metastatic cancer that we're tracking. There's also the reducing the cost of inhalers and epinephrine auto injectors. Looks very similar to legislation that was passed regarding the $35 cap for 30 days supply of insulin, saying that it's going to, for epinephrine auto injectors, capping that at $35. I think it's a supply for two of them, but capping the supplies on that, which does have, when we're looking at categorizing in our legislation for a high or low impact, those sorts of things would have usually going to have a high impact, even though it's not a lot of people it's having an impact for, those individuals whose co-payments might be $70 or $80 for the 2-pack of auto injectors now are gonna be capped at $35 of their copay for that, which is a great thing for consumers and our members who benefit from legislation like that.
Question about that, or is it limited to just like albuterol and simple like steroid inhalers, or do you know if it's like gonna cover any?
We were mad on that one. I'd have to get the clinical team involved in that one. I know kind of where it's at and generally what it's speaking about, but the specifics on it, we could get our clinical team to come and speak to that more specifically about what the general, really what the details are, what the types of things are, but we can take that back.
We've got a pharmacy presentation coming up.
Oh, that'd be great, yeah.
We'll see. So we'll.
Not albuterol.
Okay, so we got.
We did the claims.
Wow, you
Well,
watched,
and
don't see that?
my team actually, who's on the call. Watch. I knew she'd be sending it any second.
Like all insulins except for rapid acting insulin, right? So, just anyway,
Thank you for the question. And thank you, Siri, or whoever's on your watch.
That's Molly Christie.
Oh, hi, Molly. Thanks, Molly. All right, then we have 5776, accessing emergency supply of insulin. Again, more work on making sure that life-saving insulin is available. This allows for, this requires the healthcare authority to have a purchasing or a pool of insulin that's available on an emergency basis to individuals who have a prescription for it but are not able to afford it or able to otherwise access that. That they're able to get on like a 1-year basis, a 1 30-day supply of insulin from HCA for something like $10. Very affordable, or maybe we forget, not exactly sure the way of it, but just making sure that there's accessibility to an emergency supply of insulin upon need for individuals who find themselves unable to pay for that. Helping you again, closing some of those gaps, continuing to move further towards closing the gaps that exist for coverage of those things. 6127, increasing access to HIV. This is the PrEP medication to prevent infection from HIV. And that one, another sort of medication. I see probably a question.
well, you said PrEP, but this says post-exposure, so I just wanted to.
PEP, that's my bad. Yeah, the PEP. Then it's not Senate Bill 6128 because I was looking that up and it's that. 6218, okay, that's my rush. Because I was looking at 6128 and it's something about certain animals you can't take around for like traveling shows. I thought, whoa, that was awesome. I thought that was a good mistake.
That's where we start talking about pet insurance again, isn't it?
6218, providing prescription drug coverage for the treatment of obesity. This one's, I think I'm talking a lot about, you've heard like Wegovy and Ozempic, those things that are just plastered everywhere. I mean, I don't know how much money they're spending on advertising, but it was a lot. And it's got a lot of people's attention is focusing on obesity medication. That's something that, it's not currently covered in our plans outside, not for obesity. It's for treatment of diabetes, you can get the semaglutide coverage. But this is saying for, expanding that coverage for commercial plans to cover the use of those auto injectors of semaglutide for diabetes. And it has in case you're wondering, it has a significant fiscal.
I was gonna say, I've heard that the fiscal notice on that, and holy moly.
That's a big, so, but those are topical areas that they're looking at and we'll see where that lands this year or next year. I don't know if Tony had.
Those Sue questions.
Yeah, and that's kind of, geez, I went on for a while, crowded on, but any questions about legislation? Because by the next time I see you, session will be over, hopefully, and I'll give you a wrap up of where we landed with session, but in the meanwhile, happily, and any other questions.
Okay. All right, thank you, folks. Hey, thank you. Tanya, thank you.
Right on.
Tanya to the rescue. Mr. Parton. John Parton, our benefit strategy and design section manager in ERB, is here to remind us of the procurement benefit planning cycles for the PEP program, materials behind tab number 10. John, welcome.
Thank you. Glad to be here. Appreciate everybody being here, paying attention. That can be a challenge for me sometimes. So I wanted to go over really briefly, two processes that we use and they're separate, they're different, but they're very similar. So I just want to kind of highlight the differences and then spend more time actually giving you a chance to share some ideas you might have about things we should be focusing on for benefit modifications or benefits during the upcoming sessions. So start with the procurement process. The procurement process by definition is something where we're looking at not necessarily going to a full procurement, but we're renewing an existing relationship that we have with a payer or a vendor that's already gone through a procurement process typically. So our payer partners, vendors that offer different programs that we might be using now. And we're looking at potentially changing some of those benefits based on what they're seeing in their book of business, what we're seeing in our claims data with that relationship, generates the idea. And then that gets reviewed, assessed. There's some development work that goes on those, and we make a decision of, we're gonna include this as a potential modification for the upcoming benefit year. In this case, and this is one of the major differences between these two cycles, anything that gets reviewed for the procurement cycle, given that it's already an existing relationship, happens faster. So we'd be talking about for this year, a 1/1/2025 implementation date. So the teams that work on the procurement actually started working on this when the board season ended last year, at the end of summer. And now they're prepping for implementation of things that happened from that session. And then looking at this current cycle, anything new that might happen for 1/1/2025. Anything that they generate, and it's kind of shown here, the development of those designs. There are multiple parties, stakeholders that play into this. You as the board obviously have a piece of this. The executive branch here at the state of Washington, federal government, which is more of a one-way street, telling us what we need to do, rather than bi-directional. But at times it happens, right? We have meetings with federal government, share what our experience has been, and sometimes they take that under advisement. The legislature here at the state, obviously, and then individual members and our labor partners provide input. But all of it is kind of focused on those little piggy banks in the middle, right? There's got to be funding to pay for it. And we've been talking a couple different times today about the process through those fiscal notes that kind of either talk about what the funding requirements would be, or decision packages that get prepared for each of these two cycles that we're going to talk about, to allow for finance and the legislature and the governor's office to assess the financial impacts.
And it was nice that you put the board on top. That's good. Well, and you'll see why it was, yeah, it was deliberate. Again, the message here is everything.
Don't come to our labor meetings, that's what I'll say.
But we'll come back to why the board is on top in a moment. If we can go to the next slide, thank you.
It's dynamic for the audience.
So this is that yeah, exactly, right? So this is that procurement cycle. As I shared, it really started towards the end of last summer, and then we're kind of moving around in a circle spiral towards implementation for next year. And you can see all of the various steps. I won't run through them in detail because I don't want to get us back behind schedule. But it's all around assessing ideas, generating ideas, assessing them, figuring out the potential financial impacts and the administrative lift to bring them to market, and then making decisions about what we should ask for funding to support, and moving towards implementation. But again, two key points. For this year, we're looking at a 1/1/25 implementation date, and they're with existing relationships that we have for the most part. So an existing payer relationship or vendor relationship. And if we go on to the next slide, which is the benefit planning cycle. This is, now we're looking at 1/1/2026. So why in a moment, walk through the spend cycle here that we're looking at. But this is a never ending. We're always keeping ideas that have been generated. If they don't make it one year, we keep them for the next year and reconsider them. But it's kind of that same process, but there can be really short track ideas here and ones that require more time. If we have something that has to go to full procurement, it's not going to happen in that standard 18 to 24 month cycle, right? But generally, we're talking about 18 to 24 months from the moment we have the idea, we develop it, we refine it, we submit the proposals for consideration and the operating budgets, And then we have to do the decision packages for the ones that make it to that stage to do a more detailed assessment of the financial impact. If it survives that budgeting process and we get funds to implement, then we come back and start the actual implementation, planning and execution. So anything that we would be doing this year, this cycle, would not have an effective date typically until 1/1/26. Always exceptions to those rules, right? When I say it generally takes 18 to 24 months, there are exceptions. The legislature were to come out, one of the examples you saw in the updates on the legislative cycle right before this was the fertility benefit. They were to come out and say, we want this fertility benefit, it needs to include these specific attributes, and all payers have to cover it by 1/1/25. I can't say, yeah, but my cycle runs till 1/1/26. I can't do that. We have to implement for 26, right? So we have to fast track that and find a way. So generally speaking, 18 to 24 months, beginning to end. So back to the why is the board on top of that stakeholder slide. We get ideas from all kinds of different areas, but we generally like to start with the board because you all have a degree of awareness of the folks that you represent, the constituencies that you represent, what kinds of things are important to them, and what would have the biggest benefit, right? If we were to add it or modify an existing benefit to add something moving forward. And so that's why we start here, right? And ultimately, we're going to be coming back to you, either updating you what was financed in the budget, and we're now moving to implementation, or asking you for your approval. There's an implementation plan when appropriate that you need to weigh in on. So it's really why I'm here every year. For those of you that have been here more than a year, you've seen me more than once, you've heard the spiel more than once. It's fine-tuned a little bit each year, but that's really what I'm looking for, is your inputs as to what you think would be important for us to evaluate. So that's really more than the questions. I'm looking for your input and interaction about, are there things you're hearing in the market or from members or your colleagues that you think we should be paying attention to, ideas we should have with them. So I'll open it up for input or thoughts at that, or any questions, obviously, on the processes, differences.
And John, this is a process that sort of happens throughout board season.
Yep.
Yes.
Yeah.
Ideas can come at any time, but now's a particularly good time.
And I had a question that came up just in the last 24 hours. When do you get actual direct public comment on some of these things? And what's the best way to get that to you? And part of my response to that was, don't ever hesitate to send me a note or call me directly, because my team and I want to hear the ideas, right? Even if you think it only impacts you, chances are that's not the case. And so I want to hear them, and we may have something, an iterative conversation about where it actually ends up and lands. But I don't have all the great ideas. I'm interested in hearing them. Yeah.
When we have combined coverage with somebody else, not PEB and SEB, but, let's say Concordia or something like that, and we have a clause in our thing that says we will not pay more than 50% of a particular thing, specifically thinking about maybe dental. Because our birthday is before our spouses, we cannot get that paid more than half, but yet if our spouse's birthday would have been before ours, we could have had it at 100%. Because they don't have the same clause. So is that something we can look into?
So is the situation you're describing where both individuals are covered by, say, PEB and SEB? Or are they
No, we can't be,
covered somewhere
yeah,
else?
we can't be covered by PEB and SEB. No, it's independent insurance. Even like
Saying coordination of benefits,
Coordination
dental with the
benefits.
birthday.
Yeah, with the birthday.
And I believe the answer to that is no, because that's a steadfast rule as to which one is primary coverage. And then unfortunately, it's the way that coordination of benefits works, and it's the same with any dependent, right? Not just a spouse.
Not every policy has that clause, though, that says we will only pay up to what we pay.
I think you'll be surprised.
Do most
Yeah.
of them?
That's kind of an industry standard.
So it goes up to the total.
But why, if you're both paying for a policy, why would you not be able to benefit from both those policies?
Yeah, so didn't used to be that way. But now it's that coordination of the coverage between the two. And I know with my own kids, I have one who gets a service that one of the payers pays a significantly different amount than the other does. And for the provider, that's the one they want to bill, right? Because they know they'll get the, but in
Their birthday,
terms of which, yeah, I don't have a choice into which one works the provider gets
you
billed
divorce
first.
them and get it in a divorce decree. And then it would work.
Can I divorce the child?
No, you divorce the parent, you said that they live together.
Because this is brainstorming and you have questions and we can come back with
Yeah.
more details of it, but I want to make sure we capture those.
Yeah,
next
but-
week. Yeah. But
Yeah.
we know that, I mean, we know, Donna, your
My kids didn't get married because.
your background
Yeah.
and how you got involved in SEB was a very unique story. Well, unfortunately, not that unique. But looking at what the rules of the road were and having to make coverage decisions based and marriage decisions based on coverage and cost. So I totally can understand where that question comes from. So we'll look into more about it to at least be able to describe some more about it. Pam?
I'm gonna go a little higher level. I'm not gonna go into divorcing my husband or anything like that. No.
Always a way around everything.
I would really like us to continue looking at dental and vision. I'll call it the old WA plan, but it would be great to see us back up at 100%. You know, you've earned that privilege. You've gone through all your healthy care visits. We've got to get just a better plan there. And then it was good to hear that there would be a small increase in vision. But as someone who is aging and has to have multiple eye visits now, looking into a more robust
Absolutely understand both of those. I would be remiss if I didn't remind everyone that there were enhancements made in the Uniform Dental Plan for 26 days ago as another step. And then we know that there is another step in vision, but I agree that the journey on now, those benefits are not done, but I would be remiss if I didn't highlight there were improvements made in both of those in the 24 and 25 year, but totally understand.
The vision plans, it's a set dollar amount for a lot of things.
Yes.
And those dollar values are not as valuable as they were when that plan was initially put into inception, so.
Well, neither $150 nor $200 goes particularly far in hardware, as somebody who's had hardware since they were 4. Not that I appreciated the value of $1 and 4, but I can understand that it doesn't work that way, so.
And I would also throw out there, 'cause we did a lot of work in my teams last year. on What else could we do? Could we do differently with vision? And the vision market is not what it was 5 years ago either. And so the cost, the options that are out there are very different. So there's part of that is, I would never sit here and argue with anyone that there's not a certain oligopoly kind of supply chain going on in vision. But there are options that weren't available 5 years ago, and are there ways that we can take advantage of that on behalf of members? I think that's something that we continue to evaluate and unintended look at.
Can I bring up one more? Sorry about the camera. And this is like a higher level. I don't remember which report because I read all through this last night. You know, when it talks about, you know, in certain counties, we lost one provider here or one pharmacy here. If you lose one pharmacy or one provider in Thurston County, that's not a big deal. You lose it in Eastern Washington, that is a huge deal. And maybe I'm being rhetorical, but is there a way to look at, you know, losing one might be 1% one place and 20% other place because there wasn't as many providers and options to choose from. So maybe if it's in one of the other
What's the
reports.
next presentation?
Oh, I'm ahead of the game.
Just hold that thought, but not too long, hopefully.
All right, I'll save it.
Other thoughts for John? Thank you, sir.
My information's there. Please don't hesitate to reach out if you have ideas after the meeting other times.
Thank you.
Thank you. Appreciate the time.
Thanks for putting the board on top.
Yes.
There we go. Next up, Jenny Switzer. She's gonna talk to us, she's the senior account manager in ERB, and we're gonna go over some retail pharmacy trends that we are seeing.
Everybody puts the laptop in front of the
Oh,
microphone and I've just been focused on that the whole time.
Thank you, Dave.
Materials behind tab number 11. Welcome, Jenny.
Thank you. Like Lou said, my name is Jenny Switzer. I'm Senior UMP Pharmacy Account Manager in the Employees and Retirees Benefits Division. Today I'm going to provide an overview of the different types of pharmacies that we have in our network and some recent changes that we've seen with our retail pharmacies within the UMP network. On the first slide, you'll see the types of pharmacies in the market. The first one listed here is retail chains. These are those big box type stores that you see like Walgreens and Rite Aid. From 2010 to 2020, we saw industry-wide focus on acquisitions and mergers, which really grew that retail chain market. As examples, CVS acquired 1,700 Target pharmacies and Walgreens acquired 1,900 Rite Aid pharmacies during that time period. Now we're seeing more retail chains closing or filing for bankruptcies as sales to those companies have decreased. Walgreens announced in 2019 their plan to close 200 stores, and in 2021, CVS announced plans to close 900 stores. I'm going to go over more information about retail chain closures in later slides today. Regional pharmacies are pharmacies located within retail stores. Their numbers continue to increase as there have been large retail acquisitions of grocers in recent years, resulting in the addition of more pharmacies in those retail stores. The locations make it easier for shoppers and people to purchase their drugs while they're getting their groceries, and reduces the need to travel to a separate location for those purposes. Third on the slide here is independent pharmacies. Those continue to see decreases as more retail chain locations and regional pharmacy locations have opened, as well as the growth in mail order options. Mail order and online pharmacies, they offer convenience, having your drug shipped directly to the destination of your choice, and also text and app tracking of your drugs and getting those refills in place. In the next slide here, it shows the differences in the count of network pharmacies nationwide and within Washington State between 2019 and 2023. As you can see on this slide, Rite Aid does account for nearly half of the total loss in network pharmacies. I am going to discuss this in later slides. Our pharmacy benefit manager, Moda Health, continually works with their subcontractor, Novitas, to enter into new contracts to ensure that members have appropriate access to pharmacies. Hamlet's coming up, don't worry. Due to adding additional pharmacies to our network, in Washington State, we only actually see a reduction of just 5 pharmacies between this time period, 2019 to 2023. There's many changes in the retail pharmacy industry that affect availability of network pharmacies, and we'll look at some of those on this next slide. Just like any store, pharmacies open and close regularly throughout the year for a variety of reasons. So here I've listed some of the reasons. The first one is increased competition. Online businesses like Amazon and then those big box stores like Walmart are expanding their footprint and offering competitive prices and convenience. And although the addition of pharmacies and more grocery stores and more mail order options are and can be a benefit add for our members, it does have downstream impacts for those retail pharmacy locations. One of them being reduction in foot traffic, which impacts front-end sales and overall revenue. Second here is the economic impact of lower drug reimbursements that can result in reduced profit at chain and independent pharmacies. That competition from those online retailers and retail stores has led to pressure to reduce fixed costs like reimbursement rates at all pharmacies, without the benefit of additional revenue from other sources like in a grocery store. Many chain and independent pharmacies see negative financial impacts as a result of these changes. The next bullet there, not shockingly, reduced in-person traffic during the COVID public health emergency further reduced sales at chain and independent pharmacy locations. During that time, many people switched to mail order options or switched to filling prescriptions at their grocery store because of that desire to not visit as many locations in person. Additionally, state and federal regulations have added administrative burden to pharmacies. Enhanced requirements around proper handling of prescription medications, most specifically opioids, does add time and additional procedures to the billing process, which increases overhead costs of pharmacies. And then Just for an additional note here, many pharmacies have faced lawsuits and hefty fines relating to opioid drug distribution processes. Some locations have had to close or file bankruptcy as a result of these lawsuits. On the next slide, we'll look at UMP's response to these closures. Here you go, Pamela. All right. Board of Health, our pharmacy benefit manager, works to ensure appropriate access to network pharmacies for our members and includes many aspects that support pharmacies to ensure availability of locations. We do look at, this is in my notes here, but we do look at the different geographical locations. We have requirements in our contracts that MODA has to meet them because, like you said, those urban areas don't equate to the same as those rural areas. So they have to hit certain metrics on distance to a pharmacy. They're a little different, as you can see here. This is as of the 2023 Geo Access report, which had overall 99.9% of SEB members had appropriate access to a pharmacy. But you can see 99.95% of urban members had access to a pharmacy within 10 miles. 99.87 had access to a network pharmacy within 10 miles. And then 99.73 had access within, and this is rural, within 30 miles. And if anybody's ever driven up in the hills of Tenasket, you'll understand why there's a difference where 30 miles is more of a standard in some of those rural areas. A pharmacy would not be effective up in those areas. But we do definitely pay attention to that. And when we know that there have been closures of pharmacies, that's generally my initial response. Where did they close? Do we have any that closed in rural areas? And we'll look at that as I go through kind of the slides on the Rite Aid closures that we've seen. But
Could
we
you comment a little bit on the retail access overlaid with the mail order? Because I think that's sort of an interesting in Spokane, the greater Spokane region. There was a lot of outcry when KP moved into mail order only, even though it probably would have been easier than driving the 30 miles into Davenport to go to the Davenport pharmacy in that way. So I'm just curious how that intersects in the, maybe it's in the contract. I'm not sure if that's where it would be, or if that's just a by carrier.
We have in the contract that MODA will offer access to, that they will have mail order pharmacies. So right now we have postal prescription services, and Costco was added last year as an option. It's not played into these access numbers, because then 100% would have access to, right? But we don't have requirements where somebody has to use a mail order pharmacy. If we've learned anything, we know that people don't like that. I don't like being told exactly what to do unless he tells me what to do.
As he laughs.
Well, and then there's some restrictions on what could be mail order.
There are
My
some.
kid has ADHD, so we're
We gotta
always
go-
chasing to find where the pills are even available kind of thing. So, but that couldn't be part of mail order.
Yeah,
As well.
because there's laws.
So that
around.
becomes a really important role,
It does.
really important for things that you couldn't appropriately get through mail.
And I'll backpedal a little bit on my statement that we don't require members to use mail order pharmacies. There are certain medications that you do have to use. They're specialty medications, so they're very costly, or they have very special handling. They have to stay in refrigeration. They have to be delivered within such a period of time. You need a clinician to talk to you when you place your order to make sure that you understand how to administer these drugs. Those are available through our specialty pharmacy, which is a mail order, which is Arden Health. In some situations, we have made exclusions where we actually find a pharmacy that will carry this drug, and we can get the member to that pharmacy if there is an issue with the delivery. But yeah, we definitely try to promote mail order as an option for our members for those situations where it doesn't work, right? They're maintenance medications that you need every single month. They're not a medication, ADHD medication. such like that, you have to show up at the pharmacy for those. We definitely recommend it to members. It can be a cost savings for them and it's, you know, it does save time. I'm never an early adopter to anything. Like I'm wearing these fuzzy pants, right, that have been in style for like 9 months. I just bought them, finally bought into it. And I was the same way with pharmacy, with mail order. I'm like, I'm not gonna do that. I've always gone to the pharmacy to pick it up. Well, coming into this job, I signed up for mail order just to see how it worked, so that I understood the process. And now I get a text message that says it's time to refill your medication, and I just push a button and it sends it to me. I would have totally picked that up late or like called my doctor, 5 PM. Please send it right now. I'm out of my medication. So now I'm into it, but I get it. Like people don't want to be forced into it, and you have to be comfortable. So, but it definitely, mail order can definitely help bridge some of those gaps in most situations.
Rural members, are these retail pharmacies just inclusive of the big chains, or like, I imagine a lot of folks in rural areas have access to federally qualified health centers, which sometimes have pharmacies attached to them. Are those inclusive in these plans? And well, I guess that's my first.
These are the adequacy for our network pharmacies, so the pharmacies that are within network. So, which includes independent and big chain. I don't know. I see notes being quickly written over here, and expect an email telling me to follow up. So, yeah.
I guess my other question is, I guess if you're asking these folks to prefer to use mail order pharmacy, but if they're going to federally qualified health centers, which are having difficulty staying open in rural areas, the 430 or 403 pharmacy benefit on some of these specialty medications, like hepatitis C medications, for example, can fund them in a way. So is there, I guess it might not be on the purview of this, but ability to give them flexibility to choose to have FQHC pharmacies dispense these medications and take advantage of that benefit rather than going to just mail order, where the mail order pharmacy would get that benefit and it doesn't roll back to the health center.
I can say with complete confidence that when we worked on this presentation, we did not talk about FQHC. So
No,
that
we did
is,
not.
we're gonna follow up on all of that so that we don't misstate anything. So one of the things that we'll do is at the next meeting, we bring follow-up cleanup for questions that couldn't get answered during the presentation. So.
Thank you for catching me before I said anything that was inaccurate. I was pretty much gonna say
Which is, we'll bring that back.
But like, just to kind of bridge that, I mentioned on an earlier slide that, mail order has benefits to members, but it does have some downstream negative impacts too. The other bullet here on this are our response to trying to, and this kind of plays into it a little bit too, how we try to support and make sure that we have network adequacy for members, is to, Novitas, which is whatever PBM subcontractor, they work to ensure fair pharmacy pricing and contracts is applied across the board at pharmacy locations, to ensure they're not charged additional fees or penalized for outcomes that they have little or no control over. Some pharmacy benefit managers have different ways that they do pharmacy pricing or guarantees. We try to make sure that we're not, disadvantaging pharmacies by putting those restrictions in place for them. Alrighty, on the next slide, we'll look at Rite Aid and Bartell Drug, the bankruptcy that I'm sure you've heard about in the news. So for a little bit of background, Rite Aid did buy Bartell Drugs in 2020. So when you hear about Rite Aid filed for bankruptcy, Bartell's closing because bankruptcy is all together. In October of 23, Rite Aid filed for bankruptcy, and then in November, they started closing stores as a result of that. The first store closed on November 6th, and 20 stores in Washington have closed so far. There continues to be closures and will be until the bankruptcy is finalized. And Rite Aid has decided, as of the most recent news that I heard, that they would shut down 154 stores nationwide out of their 2,200 stores. And the bankruptcy is not due to be finalized until March first, so we are watching that very closely. And as more stores close, we're following up on some of the things I'll go over in the next slides about how we're responding to that, notifying members. So on this next slide, we'll look at the locations that have closed and the total number of SEB members impacted. So this is the list of stores as of a week and a half ago that have closed as a result of bankruptcy. And I included how many SEB members utilized these locations since January 1st of 2023. So like I mentioned, 20 network pharmacy locations have closed in Washington state so far. That impacted 1,132 SEB members so far that filled prescriptions at these locations. And on the next slide, we're looking at the distance to the nearest network pharmacy. So just like when a pharmacy closes and we get notified of it, one of our first questions is, are there any closing in rural areas that are really gonna be hit and impacted by this? The next question I ask is, how far do people have to travel now? And so, like I mentioned, 20 locations closed. 19 of those 20 locations have at least one network pharmacy within a half mile. Most of them, it's across the street, right? That's a lot of them, because if you look back at your slide to see where the closures took place, a lot of them like Bellevue, places like that. You got one right there. The only holdout there is Everett, and it's 0.7 miles to the next nearest pharmacy. All of the closing locations have at least 2 network pharmacies within 1 mile, and all of them have at least 3 within 2 miles. So as far as distance travel, it really hasn't had a huge impact, but we are continuing to track that.
Right, I have a follow-up question. So when you say there was like 1,300 members who were affected by pharmacy closures, right? Is there anything that is done before handoff, or is it just up to members to find that next pharmacy within the area?
I'll go over how we reacted to it and what we're doing about it, but there are actually laws surrounding that closing pharmacy has to notify the people that have filled drugs at their location. I don't know what that looks like, but I do know that they are required to notify them. And then we take additional steps to notify members as well if it's a large impact to members. If it's one small store in a heavily populated area that's, inundated with, we only had 3 members that went there and there's 5 more pharmacies around it. We don't really go overboard to sound alarms about that because the member would have been notified. Generally, if your store's closing, if you're going there often.
And these, when you're talking 1,300 SEB members, these are UMP
Yes.
SEB members.
Yes, sorry, that's
Not, but I'm thinking big picture, it impacts everybody who had, whether you were UMP, Primera, Kaiser. This is just a micro version.
It's a subset of the people using that pharmacy.
Right.
Yep.
Good call out. Did I address your question?
You did, and I just wanted to bring something up, and it's just like a thing that's close to my heart. When you say these things like there's a pharmacy within half a mile or 1 or 2 miles, that could become difficult when it comes to like a really cross-section of area with addiction medicine. A lot of pharmacies require you to know the patient before they stock Suboxone, for example, and if the pharmacy closed down, if you're required to find another pharmacy, sometimes prescriptions with controlled substances can't get transferred. You have to go back to your provider, build a new rapport with the pharmacy, et cetera. So I think for those members, it's an additional consideration to think about because it's a big change and then you have to build trust and understanding with a new pharmacy, and that could become difficult. And these 2 pharmacies might not even carry the medication, so you might have to travel.
Yeah. Great points. And we try to get as far ahead of the closure as possible to do outreach to members. Like I said, in those small situations, maybe we don't do as much outreach, but it could definitely have a big impact on people, knowing that those pharmacies have to notify the people that have filled there as quickly as possible. Or nice that there's that added part there. Bankruptcies make it a little hard because there's a lot of legal things going on that they don't really notify the public super early about which stores are closing. And so MODA's been working, they've done great about providing us with, here's what's closing now, here's what's closing now, so that we can try to get ahead of it. But a lot of times it is really short notice. And sometimes when pharmacy, and that's just talking about the bankruptcy procedures, sometimes pharmacies close with notification ahead of time, right? And so we try to do what we can, but we're kind of at the mercy of pharmacies notifying as well. Let's see, so outreach to members, kind of playing a little bit into that. We wanted to make sure the members received proper notification of these closures. We collaborated with MODA to develop letters to mail to members who utilize those closing pharmacies within the past 6 months. As new stores close, new letters are going out. The letters include the name and address of the pharmacy that closed, MODA's website and phone numbers for members to call if they need help finding a pharmacy, information on how utilizing a network pharmacy can save you money, and instructions on how to switch their prescription to their selected pharmacy. Because like you said, sometimes you can just have your pharmacy, your prescription moved. And what a lot of times what those pharmacies do, even with this, they actually transfer your prescriptions to a new pharmacy. However, there are certain drugs that you have to call your doctor, have them send it over. And so we included instructions on here are your options. Have your pharmacy transfer your prescription, call your doctor. Try to make it as clear for people as possible so that they didn't run into an issue where they need their drug right now and they don't know how to handle it or didn't get notification about how to handle that.
Also, there's cost differences as well. How are how is the member getting notified about that?
We have a pharmacy price check tool. So the same website that we provide for go online to find a network pharmacy, you can go on there to compare the pricing of the drugs between it'll bring up a list of the pharmacies in your area, the closest pharmacies to you, and it'll show you can check the price of your drug at those different locations.
So like, for example, when the Lacey one closed, Rite Aid was here, Walgreens was across the street. They said, oh, we transferred everything across the street. We just did it. But their pricing was much higher than the Rite Aid, which was, you could find another one somewhere else. So when they just do that, what recourse do you have? You can say, no, I don't want it, and then pick your own later, or you should have that choice without them just automatically doing it.
Yeah, and that's at the pharmacy level that they transfer those prescriptions to. Here's a pharmacy that we're partnering with. We're transferring your prescriptions. We don't really have any skin in the game there, but that's a good note about. I know in the past we've done communications about the pharmacy price check tool and that, because I think people have this thought that I used to have a thought. My prescription costs me $2.50 here. Well, of course I can go next door and it's going to be the same. It's definitely not. And so that's a good note that maybe we should revisit promoting that knowledge.
You want that right to make that decision when you want to make it, not told. It's not your fault the store's closing, granted, and neither is it the pharmacist. I get that. But you shouldn't just automatically say, oh, it's going to be here, but now your price is going to be this. So you may want to look at something else.
Making sure people are aware that, they can say, no, I don't want to get my drugs there.
Informed decision.
That's a good point. Things to think about. So in addition to these letters, we created 2 smart health activities. One was focused on network pharmacy information. So how using a network pharmacy can save you money, price check tool, how to find a network pharmacy, things like that. And then the second one, because we know that people struggle with, wait, how do I even transfer a prescription? Because we go to the doctor, our doctor says we need a prescription, we just show up, there it is, right? Well, what do you do when it's a maintenance medication and you've never had to switch it? So we did do a smart health activity that was specific to here's your options of how to get your prescription transferred. And then also on our UMP website, we had an alert so when people logged into their account, it just alerted them that there are pharmacy closures taking place. Click here to get more information. Again, took them to that pharmacy locator tool and more information about how to transfer prescriptions and all that. So That does bring me to the end of my presentation. We're gonna continue to watch this through the end of the bankruptcy proceedings, and then, I mean, it's just a standard we watch to make sure that we have adequacy for our members. I live in a rural area, and I don't want to have to travel, 35 minutes to Olympia every time I need to get a prescription. So I'm a member too, so it's important for me and important for our members. So.
Any other questions for Jenny? Okay, thank you so much.
Thank you.
We're gonna go ahead and take a 10-minute break. We'll be back at 2:40.
Luke, sure, just gonna wait a few moments and then 2:40, be ready.
That was actually his.
There, is that better? I can, yeah, I had my my microphone was up on my head. Must be. She was said something about the beach.
Thanks. Appreciate the support.
Off the rails, man, off the rails.
Okay. All right. Here we go. Luke, are you with us, Luke?
Yes, I am. Can you hear me?
We can hear you. Luke is our clinical pharmacist in the Clinical Quality and Care Transformation Division, and he's joining us to talk about the Inflation Reduction Act. His materials are behind tab number 12. You're up, Luke.
Yeah, thank you, Chair McDermott and members of the board. As mentioned, my name is Luke Dearden, and I'm a pharmacist that helps support the ERB team. Next slide. So the objective of my presentation is pretty straightforward. It's just to provide really a high-level overview of pharmacy provisions within the Inflation Reduction Act. Next slide. So as a refresher, the Inflation Reduction Act was a huge piece of legislation. It was signed by President Biden in August of 2022. My presentation is going to focus really on 4 main pharmacy provisions. All of these center around Medicare Part D programs. So number 1, it restructured Medicare Part D benefit design. Number 2, it enables the federal government to negotiate drug prices with drug manufacturers. Number 3, it limits manufacturers' ability to increase drug prices at a higher rate than inflation. And then number 4, it capped insulin cost share at $35 per month. And as I mentioned, these apply to Part D programs. These provisions do not directly impact the SEB program population. However, I think it's important to stay up to date with what's going on.
And Luke,
Next
this is
slide.
Dave. I'll just also add, there were various iterations of this. Policymaking is policymaking. And there's various ideas around it. Before the Inflation Reduction Act was passed and signed, there were versions or discussions about some of these being more broadly in the commercial insurance market or employer-sponsored insurance. And there are attempts to expand the Inflation Reduction Act to apply wider commercially. So that's another reason to be aware, because now the policy, one side of the policy conversation is about expanding the Inflation Reduction Act. And obviously, the other side of the conversation is retracting the Inflation Reduction Act. But knowing what the current status is important for both sides of that equation.
Yeah, great point. Next slide. So the first one is restructuring the Part D benefit design. This is fully effective in 2025 with a smaller modification that started in 2024. Without getting too into the weeds here, costs are shifted away from members. So a big example of this is that maximum out-of-pocket costs will be $2,000 for Part D programs starting in 2025. Previously, Medicare Part D plans did not have a maximum out-of-pocket cost for members. So like I said, also it increases responsibility of drug manufacturers in the catastrophic coverage phase. That's the phase after the out-of-pocket maximum is reached. And then finally, it limits premium increases to no more than 6% from the previous year. So financially speaking, this is really a big win for Medicare members. Next slide. Number 2 is the IRA requires the federal government to negotiate drug prices, certain drug prices. Although this process has already started, the negotiation prices will be effective starting plan year 2026. In order for a drug to be eligible for negotiation, it can't have a generic that's available, and it had to have been approved by the FDA for at least 7 years for a traditional molecule drug or 11 years for a biologic product. One caveat of this, though, is that drugs picked for negotiation must be covered by all Part D plans, generally speaking. And this table on this slide shows the number of drugs eligible for negotiation by year. So 2026, 10 were eligible. 2027, 15 were eligible. 2028, also 15 were eligible, but the federal government is allowed to include Part B or provider administered drugs into the mix. And then 2029, moving forward, 20 drugs per year will be eligible for this negotiation process. Next slide. These are the 10 drugs that were selected for 2026. So as a pharmacist, I had to bring actual drugs into the conversation. You can see these are pretty big players, especially in the Medicare space. So we have Eliquis and Xarelto. Those are anticoagulant drugs. Jardiance, Januvia, and Farxiga are diabetes drugs. Entresto is a heart failure product. Enbrel and Stelara are for a variety of immunologic conditions. And then Imbruvica is a cancer drug. And then the last one, Fiasp/Novolog, that's Novo Nordisk's short-acting insulin product. Next slide. So number 3 is the bill provides drug price increase protection. This also just applies to the Medicare programs. This was effective 2023 and applies to Part D drugs and also some Part B drugs. As a reminder, Part D are the drugs you get through like the pharmacy benefit, self-administered. Part B, generally speaking, are drugs that are provider administered drugs that you would get through a medical benefit. Through this, drug manufacturers will be required to pay the federal government for price increases above the rate of inflation. There is some speculation here that manufacturers will just simply inflate launch prices on new drugs to kind of get around this. However, time will tell if this actually plays out. Next slide. And then finally, the cap on insulin cost share. Perhaps this got the most media attention. This was also effective 2023. It requires a maximum cost share of $35 per month for insulins. And under the Inflation Reduction Act, it only applied to Medicare Part D plans. However, Washington State already has a law that caps insulin cost share to $35, and that applies to commercial plans as well, including the SEB population. Even though the SEB population also has preferred insulin products with a lower cost share than $35 as well. I do want to point out here that this does not actually lower the cost of insulin. It simply shifts the costs from the member to the payer. And next slide. And I guess that was the presentation, and I'm happy to answer any questions.
Were you surprised by that, Luke? He's like, oh, I thought I was gonna say some more. All right. Do we have
I think
questions?
Luke's remembering his presentation next week.
Probably.
Yep.
Do we have questions or comments for Luke? Seeing none, Luke, thank you. Appreciate it, sir.
Yeah, thank you.
All right, next up. Ellen Wolfhagen is she's the retiree benefits manager in ERB and is gonna provide us with an update on the legislative report regarding retirees, the PEP program, and engagement efforts with the retiree population. Materials behind tab number 13. Good to see you again.
You too, Chair McDermott, very nice to see you, members of the board, thank you for having me here. So just a note, there was a question earlier, and I just want to state that published Medicare premiums, the rates that are available on our website, are after that explicit subsidy that Tanya and Kate talked about has already been applied. So that premium that we show is what the member actually pays. As you know, K-12 retirees transfer into PEP. So I want to give you a little background on our recent retiree engagement activities. Next slide, please. So we've been, as Dave said earlier, we've been working quite a bit on increasing our retiree engagement. One of the things that we've done is create a roadmap that helps people who are thinking about retirement understand what they need to do to prepare for it. There are lots of moving pieces. You know, you have to deal with the Department of Retirement Systems, you have to deal with Medicare, you have to deal with Social Security. You may have to deal with requirements from your employer. So we're trying to lay this all out in a logical format so that people have an easier way of dealing with the things that HCA deals with and the things that are outside of our purview. We have a retiree engagement webpage. It includes frequently asked questions and common myths. If you look at it this week, you'll see some older information. It's going to be updated in the next week or so, so there'll be lots of new information. The retiree newsletter, so this is a new newsletter that's going to come out in February for PEB retirees. We updated the format for the retiree enrollment guide, so that included some different presentations of information, benefits across different plans in a easier to understand visual format, some maps that show where coverage is available. And as Alyssa mentioned earlier, we had more benefits this year and we had more representation from HCA. I myself spoke to a number of K-12 about to retire folks. There is a transition between PEB and between SEB and PEB, and people have a lot of questions about that transition. So we're working to make that as easy to understand as possible. I also want to mention that both Dave and I did podcasts for the Department of Retirement Systems, and those are available on the DRS website. And mine specifically talks about the Medicare plans that are available in PEB and how they interface with Medicare. Next slide.
I do just want to highlight that we have always sent newsletters to retirees, but they've been incorporated as a singular newsletter that straddles the employee retiree world. And we've gotten just a lot of feedback that there are parts of newsletters that apply to one population and not the other, and it would be easier and more easier to track for retirees to have things that is just things that are related to them. For example, the FSA and DCAP benefit only applies if you're an employee. There is no long-term disability when you're retired. Things like that that just are more natural. And then we're looking at things like consistently increased font size, which would be helpful for the retiree community. And so, you know,
please increase the size of my slides.
So just, it's an opportunity. It does require just a little bit of straight work to kind of segment out, but there are a lot of value added by making it a retiree-centric newsletter and then having a more employee-centric.
I also want to point out that my title as retiree benefits manager is recognition that the retiree community needs an advocate as well. So I appreciate that.
And actually, and on that note, Tanya highlighted in her presentation that the agency had 2 different decision packages related to the PEB-SEB program work. She highlighted the benefits alignment one. The other one is asking for more staffing support to support the Medicare team, including cloning Ellen. Or her position, not actually cloning her.
Glad you
clarified.
Okay, so the listening sessions were focused on what people like about their plans and things that it was an opportunity for them to share things that they didn't like about their plans or things that they'd like to see changed. We did a number of webinars, and by we, I mean I, and those included various associations. And I'll talk more about K-12 specifically in a second. And I created an inbox. It's a rather long email address, but HCA PEB Medicare at hca.wa.gov is a specific inbox where people can provide general questions or comments or concerns. We've heard a lot of feedback through that inbox, as well as specific questions when people have situations with their plans. Next slide. Is there a slide in between? Thank you. So specifically with K-12, I did webinars for the Washington Education Association that was attended by over 200 people. And what I find in these webinars is I heard a webinar and then I told my friend to listen to that webinar and then they told their friend to listen to that webinar. So 200 people on the initial is about 400 people when you talk to everybody about it. And then the Washington State School Retiree Association, they had over 100 people on their webinar. And then obviously at benefits fairs, we talked about, again, preparing folks for retirement and highlighting the differences between SEB coverage and PEB coverage. Next slide. So as Kate mentioned, there was a legislative report that was done in December. And this is the operating budget language that was pertinent to that. And next slide. So that legislative report really has two parts. One is a report out on the listening sessions that we had. There were 24 sessions, as Kate mentioned, February through May. We had 3 public forums and a total of over 200 people attending one or the other of those. The legislative report also provided an analysis of the 50 states and what they offer for public employee retirees. And it's important to note that not every state covers public employee retirees with coverage. So we're very fortunate in this state. The report also looks at potential impacts of various options that could reduce the UMP Classic Medicare premium. And there is a link on the slide that would work to give you the actual. With that, I'll open it up to questions.
Questions for Ellen?
Are you doing the webinar on February 14th? Oh, I'm going to one on February 14th for.
Not that I am aware of.
So that's a firm maybe.
We'll see what's on my inbox. Thank you so much.
Thank you, Ellen. All right, that concludes our presentations today. Abe, you want to give us a update of what 2024 is going to look like for us?
Yeah, amazingly, we're back on schedule pretty much, so I can get us behind again. So I've tried to look out across the year and think about some of the things that I anticipate are coming, and most of you on the board will maybe appreciate this little joke. We do have policy and rules. We have quite a few of them that are coming back to you for review because with the PEB program transitioning to standalone vision carved out plans similar to how SEB is, we get to revisit all the dual enrollment resolutions because of that interaction of dual enrollment. So I believe there's 8 or 10 resolutions that'll come to you next month just to kind of walk through some of those changes. But you know, at first I was like, wait, we have to go back to the SEB board about that. I was like, yes, because there were dual, there's a handshake there between the 2 programs. So there's similar resolutions between the 2 boards that interact with each other. So there will be more policy resolutions than just dual enrollment, but be prepared in March to have a little bit of deja vu as we revisit the dual enrollment prohibition so that we can implement that change that's happening on the PEB program for people. Kind of alluded to this earlier in the year, or earlier in the meeting. I know we're all very interested in the rate development process. Just a reminder that really kicks up in earnest for the board. We'll begin talking about that in May in executive sessions, and rate development time is prime time for June and July. As I said, the agency has been in conversations with Kaiser almost since last board season to keep working on that area, and we're going to be dissecting even more what happened during open enrollment so that we can bring that to you. And then, we'll obviously talk about the results of legislative session. We're going to be really beginning our preparations for this next biennial budget. I know everyone's thinking, we're only 15, 20 days into this session and we're already thinking about next session, but that's just the way it goes. And starting to prepare for some of those longer term pieces. And we'll be stabilizing and giving you information about anything that's going on with benefits 24/7 as we continue to work on some modernization of that. We already have some things in the pipeline that might be worth sharing with the board. And then of course, at least next month, Kristen will be here to talk about Smart Health and give you an update on that transition and how that's going. So just a little bit about the board season, and I'm going to hand it to Chairman Durham.
All right, we're at the public comment portion. Is there anyone in the room who's providing public comment today? Indicate by raising your hand. Seeing none. Is someone out in Zoom land wanting to do public comment? Please raise your Zoom hand and Mackenzie will be calling those individuals out. Nobody with a hand up, okay. Speak now or forever hold your peace.
Or come back next month.
Or come back next March.
March.
Yes.
Oh yeah, no, it's not February.
Yeah, our next meeting is going to be March 14th. That'll be the first meeting of a regular board season. Dave, any final comments before we adjourn?
I'm just amazed we got back on schedule.
We got back on schedule. I just want to thank everybody for today's meeting. I know it's a long meeting, but I do appreciate everyone being here and the comments from the board, the engagement. Looking forward to this season. Thank you to all the staff who got all this ready. We're getting better at hybrid. It's a learning process. It's hard. We still struggle with it sometimes, but we are getting better at it. So thank you all. This meeting is now adjourned.